Good morning, everyone. And I believe our first speaker has arrived, Dr. Luna. Good morning, Dr. Luna.
Hi, good morning.
Hi, good morning, Dr. Luna. Thank you for coming to our webinar. So today you will be the first speaker, but please let me introduce our speakers first and do the opening for the webinar. And then after that, we can start with your session. Okay, so good morning, everyone. Thank you for joining the Oncology collaboration webinar with the theme Multidisciplinary Insights and Innovations in Cancer Care. I'm Megawati, and I will be your host for this event. The webinar will run from 8 a.m. Indonesian Western Time to 1 p.m. Indonesian Western Time on Zoom and YouTube. I'm speaking to you all the way from Hungary, actually, in Central Europe, where it's currently 2 a.m. in the morning. So while most people here are fast asleep, I couldn't miss the chance to be part of this incredible event with all of you. So grab your coffee, or in my case, something to stay awake, and let's make this an engaging and insightful session together. Before we begin, let me outline today's agenda. So, Dr. Luna will present treatment of metastatic HER2-positive breast cancer for our first session. And for our second session, Dr. Professor Soman Sundaram will provide insights into diffuse large B-cell lymphoma treatment updates. For our third session, Dr. Lan An we'll discuss current treatment strategies for EGFR mutated non-small cell lung cancer. For our fourth session, Dr. Agus Jati Sunggoro will talk about enhancing survival in advanced triple-negative breast cancer, TNBC. And for our final session, Dr. Prabudi will share updates on current surgical approaches in breast cancer treatment. So each session will be followed by an interactive discussion We encourage you to actively participate by using the raise hand feature on the chat or the chat box for your questions. Now let's start this event by singing the national anthem, Indonesia Raya. Thank you for your participation. I would like to beg your pardon and apologies. So our second session will be hosted by Dr. Agus, and then our fourth session will be led by Professor Soma Sundara. All right. So we would like to inform you that the Zoom chat feature is strictly for discussions related to the topics being presented. If you have any questions or technical issues, such as with Pelataran Sehat platform, please reach out through the WhatsApp group. And the LMS platform running will only begin at around 10 a.m. Indonesian Western Time. So we kindly ask participants to focus on the material being presented in this webinar first. So before we begin, let me introduce our first speaker, Dr. Hardy Glorian C. Luna. Good morning, Dr. Luna.
Good morning.
Morning. So Dr. Luna is a board-certified oncologist with an exceptional background in breast cancer treatment, particularly HER2-positive metastatic cases. Some highlights of her outstanding achievements, including global expertise. Dr. Luna has completed advanced training in breast cancer treatment at Massachusetts General Hospital under the Avon Global Clinic Program. Awards and recognition. She was recognized at the European Society for Medical Oncology ESMO Asia Congress for her work on early breast cancer and has received multiple international grants for her research in oncology. Research leadership. She has spearheaded groundbreaking studies on breast cancer management, including molecular profiling and integrated cancer initiatives, and serves as research head at the National Kidney and Transplant Institute. Consultative excellence as a consultant at top institutions like St. Luke's Medical Center and the Lung Center of the Philippines. Dr. Luna brings practical insights from her clinical practice to her research. Today, Dr. Luna will share her expertise on treatment of metastatic HER2-positive breast cancer. Please join me in welcoming Dr. Luna.
Thank you very much for the kind introduction. I'd like to thank also the organizers of this session, this forum, for the kind invitation. Okay, I'm sharing my slides. Hold on. All right. So here's my assigned task for today. Discussion all about HER2 metastatic breast cancer. So you can all hear me clearly? Yes? You can see my slides? All right. So we have here the ESMO Living Guidelines. So most of my slides are courtesy of ESMO because it's called Living Guidelines because we continuously update and learn that there are a vast amount of evidences, data, as well as molecules along the way that could enhance a seemingly aggressive disease, HER2 positive breast cancer. So we all know that in the first line of treatment, if chemotherapy contraindicated, trastuzumab plus minus pertuzumab will be an option for HR positive, HER2 positive disease. If there are no chemotherapy contraindications, docetaxel or paclitaxel, in addition to trastuzumab pertuzumab, will be recommended, followed by maintenance treatment with trastuzumab and or pertuzumab plus minus pertuzumab together with endocrine treatment until progression. If HR positive again, no, if you have chemotherapy contraindicated, you have your trastuzumab pertuzumab given until progression. And if no chemotherapy contraindications, you have docetaxel, paclitaxel together with trastuzumab pertuzumab for more or equal to 6 cycles, followed by your maintenance trastuzumab pertuzumab until progression. In the second line treatment, it gets more interesting because the consideration for active brain metastasis is recommended to be determined. If this is local-regional, localized, local intervention indicated, you need to categorize if it has 1 to 10 brain metastasis with prognostic or favorable prognostic factors, wherein an option for local treatment such as your resection and SRT can be done. If more than 10 brain metastases, in addition to unfavorable prognostic factors, whole brain radiation treatment is indicated. If local intervention is not warranted, second-line treatment with tucatinib, capecitabine, or trastuzumab can be given. And this is preferred over your TDXT or trastuzumab deruxtecan. If no or unstable brain metastasis is determined, you have your trastuzumab deruxtecan or tucatinib capecitabine. Trastuzumab can be given. And not only in the second line, but we have determined that patients can go on to have another set of progression. So in third line or beyond, you also have your local form of treatment in your brain metastasis, if active. If local intervention not indicated, you have still your tucatinib, capecitabine, trastuzumab, followed by trastuzumab deruxtecan, and subsequently lapatinib, trastuzumab, or trastuzumab, margetuximab, and neratinib can be given afterwards. And we all know that Cleopatra study has became a standard of treatment over time due to its very durable response as well as overall survival. 56.5 months median overall survival was documented by giving your Perjeta plus Herceptin together with your docetaxel. This is your Cleopatra design. While Emilia's study also gave us an option for improved overall survival with your TDM1 giving us 64.7% uh, median OS at 2 years compared with 51.8% with your capecitabine lapatinib among those with HER2-positive metastatic breast cancer patients. But newer TKIs are on the way, such as in your HER2 climb, wherein you have your tucatinib, trastuzumab, capecitabine design, compared with your placebo, trastuzumab and capecitabine, which offered a positive PFS data, giving us 33% progression-free survival at 12 months, compared with your placebo trastuzumab arm. NALA trial, also with your capecitabine neratinib among your HER2-positive metastatic breast cancer, offered an outstanding hazard ratio of 0.76, giving a superior PFS of 16% with this regimen compared with lapatinib capecitabine regimen offering 7% of PFS rate in 18 months. And this is also, this newer TKIs also translate with superior OS data. For your HER2 climb, tucatinib, trastuzumab capecitabine, median overall survival was as high as 21.9 months compared with your trastuzumab capecitabine placebo arm, giving you only 27% median overall survival rate at 2 years, while OS was outstanding at 24 median overall survival with your neratinib arm compared with lapatinib capecitabine at 22.2 months. But this the restriction is around 48 months determination. So we all know that the design of the HER2 climb, TDM1 plus tucatinib plus or placebo determined PFS by investigator. And this trial, you see there that there were planned for 331 PFS event to provide 90% power for hazard ratio of 0.27. And with the first two interim analysis for OS at time for the primary PFS analysis, if the PFS result was significantly positive, and they determined that this trial had at least improved PFS of 9.5 months with your TDM1 plus tucatinib versus your TDM1 and placebo. So this combination offered superior brain mets penetration, and you see there median PFS of 7.8 months in the TDM1 tucatinib arm compared with your TDM1 plus placebo are offering 5.7 months median PFS. And this not only goes to show that you have a good penetration in brain, but also cranial overall response as high as 42%, with complete response in 4.3%, partial response in 37.8% in your TDM1 plus tucatinib arm, compared much higher than your TDM1 plus placebo. OS probability was also not reached in your combination arm TDM1 tucatinib compared with your TDM1 plus placebo, giving only 38.0 months. And there's also the trastuzumab deruxtecan molecule among those with unresectable or metastatic HER2-positive breast cancer, even if previously treated with trastuzumab and taxane in the advanced metastatic setting. So in this population, they were randomized 1:1 to receive TDXD at 5.4 milligram per kilogram every 3 weeks versus your TDM1 at 3.6 milligram per kilogram every 3 weeks. Primary endpoint was PFS. Secondary endpoint was OS. And you can see here an outstanding PFS, superior PFS rate of around 28.8 median progression-free survival compared with your placebo TDM1 of only 6.8 months. This translates to 4 times increase in your PFS rate compared with your standard of care arm. In addition, you'll see the overall response rate in your lower left, giving us more complete responses in 21%, confirmed ORR in 78%. This is at least twice or higher than your TDM1 arm. You'll see also less patients in progression, 1.1%, more durable, more partial response in 57.5% in your TDXD arm, and stable disease in 18%. Median duration of response was noted to be also increased at 36.6%. So these are all statistically significant and translates with an overall survival of 77% at 24-month cutoff, with TDM1 giving only 69.9%, and hazard ratio was 0.64%. So this also shows the updated OS, giving us a consistent, durable response with your TDXD and translates into your OS rate of 62.5% at 42 months, while only 50.1% in your TDM1 arm. And goes to show also the adverse events, mainly expected you have your drug-related ILDs and pneumonitis rates, similar with other TDX3 trial. And the ILD pneumonitis rate increased from 10% in the interim analysis to 15%. For additional grade 1, 8 additional grade 2 AEs, and no additional grade 3 events were noted. And the overall incidence of grade 3 serious AEs were low at 0.8%. And also the brain mets, one of the key areas that we're looking for. Brain mets, this is the design. They did a pooled analysis in Destiny Breast 01, 02, and 03, and they did show an intracranial overall response rate of 45.2%, complete response in 16% in your TDXD pool, and partial response 28.8% in your treated stable brain mets. And you still look in the next bar, for TDXD pool offered 45.5 complete response, which constitute 15.9% of complete response, while 29.5% partial response in your untreated active brain mets. So this is very significant, and you'll see the TDXD water plot, the shrinkage of brain mets in response to TDXD was more prominent, whereas in the comparator pool, brain mets showed less of a response. And this is an exploratory CNS PFS analysis. You see there in your left side, as much as 8.7 months, 12.3 median PFS was demonstrated by TDXD, a lot higher than your comparator at 8.7 months among those with stable or treated brain metastasis. And look over to your right, even in untreated or active brain metastasis, TDXD has a very good wide separation of curves, and this TDXD offered 18.5 months median PFS activity compared with your comparator arm. So this is very significant. So the Tuxedo 1 study, it also is another study demonstrating with superior or demonstrating trends for tumor size reduction, as well as benefit in terms of PFS and OS. And these are the studies in along the horizon that will be determined later on among leptomeningeal metastasis and the activity of trastuzumab deruxtecan. Now we talk about future directions wherein TDXD will be moved into the first line of treatment, as you can see in this slide. And this report will be, I think, given in the San Antonio Breast Cancer Conference, and will look into the probability of trastuzumab deruxtecan in the first line setting, and the current issues will be the subsequent lines of treatment. And these are other ongoing studies in the HER2 space. And also they also designed some trials exploring after a sequence of molecules, say THAP for 12 weeks, TDXD for 18 weeks, followed by TDM1 tucatinib for 12 weeks, and also HP or trastuzumab pertuzumab tucatinib for 1 year, and then exploring if stopping treatment will also be an approach that we could consider monitoring the percent of patients with progression-free at 4 years. So this will be an interesting set of data. And also optimizing the first-line treatment in HER2 space, especially the ones with overexpressing HER2, no? So this is a phase 2 trial exploring the maintenance FESCO, trastuzumab pertuzumab, followed by trastuzumab deruxtecan as an induction treatment. So these are current studies, but also in the HER2 space with the ADCs, we know that ADCs have different antibodies, linkers, and different payloads, and they have different trials to support their indications. In this HER2 low metastatic HR positive disease, we have the Destiny 04 trial, enrolling those who had 1 to 2 prior lines of chemotherapy, and we define HER2 low, no, with IHC 1 plus or IHC 2 plus, but with FISH negative. And this patient were randomized 2:1 to receive TDXD versus your physician's choice, capecitabine, eribulin, gemcitabine, paclitaxel, paclitaxel. So the key endpoint here is the primary progression-free survival, followed by your key secondary endpoints, overall survival in HR-positive patients, and PFS in all patients. What is important here is that TDXD had very good activity among your HR positive, HER2 low. So we defined that a while ago, HER2 low population. So offering OS survival advantage as well as PFS advantage. And we have here an illustration of how many percentage is the HER2 low, so around 60 to 65 HER2. But there is a category of HER2 ultra low, which is 20 to 25%. And the absent to no observable IHC 0 is still with HER2, but defined as 0 to 10% in terms of HER2. So this is the one which Destiny Breast 06 would like to explore among your chemotherapy naive setting. So they wanted to explore HER2 low and what is the activity of TDXD in this space. So they enrolled this population and then randomize patients into TDXD versus your physician's choice. And bear in mind that 30% here had primary endocrine resistance, 30% had de novo metastatic disease, 3% bone-only disease, 6% with liver metastasis, and HER2 ultra low, similar to HER2 population, was noted. And also, there's a median 2 prior lines of endocrine treatment given. 89% had prior CDK4 inhibitor, and 30% had other targeted agents, and as much as 54% had chemotherapy for early stage disease. Primary endpoint was PFS, and here demonstrating superior PFS with your PDXD with median PFS of 13.2 months, 5-month difference with your comparator arm at data cutoff of 12 months. And in the HER2 lows, also in terms of overall survival, superior overall survival was demonstrated by TDXD at 87.6% at 12-month cutoff, compared with your 81% in your TPC, in your 12-month cutoff. So 20.1% of patients in the TPC group received the TDXD post-treatment discontinuation. And this goes to show also that in ultra-low, there's also a benefit of giving your TDXD. You see here the PFS giving us hazard ratio of 0.78%, TDXD giving us median PFS of 13.2 months compared with your 4.9-month difference compared with your TPC. And this translates to an overall survival of 84% in your TDXD population versus 78.7% among those your TPC population in a 12-month cutoff. Hazard ratio was statistically significant. So this highlights that PFS improvement with TDXD versus physician's choice in HER2 ultra-low was consistent with results in HER2 low population. And also in the response rate, the PFS subgroup analysis, whether they had IHC 1 plus, 2 plus, and ISH negative, whether they received prior CDK4/6, prior taxane use, a number of lines of endocrine treatment, endocrine resistance, whether they know primary, secondary resistance, presence or prior use of chemotherapy, also with liver or no liver metastasis. These they all benefit with TDXD administration compared with your physician's choice. And you see here the comparison between your HER2 low on the lower left and also HER2 ultra low. You'll see their consistent confirmed overall response rate of as high as 50 to 60% in both HER2 low and HER2 ultra low population. This is very good. And you'll see their water plot is showing shrinkages in your diameters, in the sum of diameters of your lesions from baseline in your TDXD more than your TPC population. In terms of safety, you'll see they're consistent with the prior trials. You'll have more of nausea, fatigue, grade 3 or more AEs were noted in TDXD, include your neutropenia, anemia, and leukopenia. So the most common treatment-related adverse effect associated with treatment discontinuation is pneumonitis, which occurs in 5.3% in your TDXD population. Left ventricular dysfunction was noted in 8.1% of any grade. So TDXD showed a clear efficacy advantage over TPC as first-line chemotherapy. There's no OS benefit to date. Crossover may impact this endpoint. More toxicity was noted, like your grade 3 or more AEs, and fatal AEs were also noted, although exploratory at this point, and also your similarity of efficacy in the ultra low to HER2 low suggests this is a reasonable and effective option in this subset. Also in the ultra low, there's still a question of definition. It's a challenge for our pathologists, but multiple new assays are in development. And Destiny Breast 15 will evaluate clinically HER2 zero population. So this is our current flow in your HER2's HER2 HR space, endocrine therapy is still your first line of treatment. And then on the second line, you have your biomarkers determined, the PIK3CA, ESR, checking for druggable targets. But determining HER2 low or ultra low in the second line is recommended for you to offer subsequent lines of treatment, which has approved indication for your trastuzumab deruxtecan in the first line of treatment, or a second line of treatment after chemotherapy. And in your HER2 zero, we're waiting for further evidences, but right now we have chemotherapy among HER2 zero, and then options of sacituzumab govitecan in the line soon. So here's the sacituzumab govitecan, TROP2. We all know they are all expressed in all subtypes of breast cancer. They are linked with poor prognosis, and the action of sacituzumab govitecan is demonstrated in your TROPiCS-02 for HER2 and then HR positive HER2 disease. And you see here a demonstration of superior PFS and then also OS. Tropion 1 also has your Dato-DXd in your HER2 low space, no? So basically, demonstrating also PFS and also OS benefit. And these are also the future trials demonstrating the current trials demonstrating activities in the brain metastasis. Here, TDXD was given among those with baseline stable or active brain metastasis with primary endpoint of PFS. And you'll see there that among active brain metastasis in this population, they had demonstrated overall improvement in terms of PFS. You see there 62.9 months in your TDXD population, as well as 59.6% PFS rate in your active brain mets population. So you see here active brain metastasis, they have a CNS PFS of 58.9% and confirmed ORR in 71.7%. And OS among this population is your as high as 90%. Again, with your TDXD, you have your ILD pneumonitis, grades 4 to 5 are also noted, but a bit in a lower percentage. So it's very important to monitor for ILD. Also, treatment should be strictly followed. Significant pre-exposure and or ongoing exposure to corticosteroids is a risk factor for serious ILD pneumonitis, necessitating close monitoring of these patients. And given the frequency of co-occurring opportunistic infections, particularly presence of significant corticosteroid exposure and lymphopenia, the potential need for PJP prophylaxis warrants clinical investigation. Again, so these are the other the recommendations along the way with your HER2 Climb, Destiny Breast 12, and of course with other ADCs, we need to know when to consider sequencing for this. But it's very nice to know that there's no significant association between the HER2 IHC expressions and also the ORR or PFS rate. So whether you have HER2 null, ultra low, and HER2 low, similar activity was demonstrated. It's just that in different trials, you see there are different drug antibody ratio, but you see there that there's a promising activity with manageable CT profiles among these TDXD performance among these HER2 null, HER2 ultra low, and HER2 low population. So here it's just to demonstrate that you have your molecules IB1354 in the horizon, demonstrating also activity by giving us good ORR and also ORR in HER2 positive and good ORR as well in your HER2 low population. And it's very important to know that samples for central testing should also be determined and the concordance between central and local results. For central testing may not have the sample used for the central testing may not have been the same as that used for the local test result. And this is just a study showing that there that there could be some tumor characteristics that can be different and but whether you have primary or metastatic in terms of tumor biopsy and also type of collection, these parameters in the HER2 low all favor TDXT treatment. And again, it's very important to know the concordance between the central local lab results. Like in this case, there's the HER2 low concordance is 77.8% in the central lab and local lab, but HER2 zero, there's a 22% concordance. So the question is, by treating these patients with TDXD, are we exposing them to ineffective therapy? And this goes to show that there is no risk, as we already know that the majority of these patients can significantly benefit from TDXD in as much as 94%. So this is the Destiny Breast indication. So 2 out of 3 patients would have missed out on an extremely effective treatment. As shown here, the concordance of local lab and central lab is 35.0% in your HER2 null population. And 1 in 4 patients with local IHC0 are improperly denied access to a very effective treatment. And this HER2 low concordance between the central lab and local lab, securing only 24.5% of concordance. Okay, so it's very important that archival assessments with HER2 IHE0 result must be reevaluated unless they are already account for evolving therapeutic landscape, including Destiny Breast 6, TDXD benefits in HER2 low and HER2 ultra low tumors. Testing HER2 on primary or metastatic lesion has the same predictive value. Rebiopsy remains an option in case of HER2 null or HER2 zero results. So evaluating beyond the target, there are trials along the way. And thank you very much for your kind attention.
Thank you, Dr. Luna, for the valuable presentation. We will now proceed to the discussion session. So please use the raise hand feature or the chat box to ask your questions. In the meantime, we have already had some questions here from Dr. Debbie. Thank you for your insight, Dr. Luna. In Indonesia, most patients with HER2 positive breast cancer are still treated only with trastuzumab and are not even close to accessing ADCs due to the high cost of it and the strict restrictions of the NHC system. How is it in your country?
Similar with Indonesia, we have very slow uh, in securing ADCs, but we do have trastuzumab deruxtecan now. I know there are variables along the way like permissions, registrations, but soon I hope they will be able to be accessible because it's a very effective medicine and we all need to be familiarized with the side effects as well. So it really is a challenge among nations such as ours.
Thank you so much for the answer. So, any other audience who would like to ask questions, you can use the raise hand feature or the chat box. In the meantime, we have more questions here. Um, how do you choose the best HER2 targeted therapy for patients with other health problems like heart or liver issues?
So we always encourage a multidisciplinary team um approach in general. Heart conditions, we select those candidates with very good ejection fraction, and also consider comorbids. We refer to our cardiologist for clearance in order to administer prior to each chemotherapy with anthracycline and trastuzumab or trastuzumab. So we usually optimize or balance between the benefits over the risk. In terms of liver metastasis, securing liver evaluation as well as gastrointestinal specialist clearance will be of benefit. We did some local study in both cardiovascular and also cardiovascular and liver metastasis incidents, as well as determining the safety uh, and also the incidence of quickly giving clearance for different types of cases. So what we found out is that optimization of the heart prior to administration of anthracycline and also um, your trastuzumab and or trastuzumab trastuzumab uh, pertuzumab can also improve outcomes of patients and the condition of the heart prior to this prior to administering your chemo and or anti-HER2 agent. So giving ACE inhibitors as well as your optimizing cardiovascular status, hypertension, and also um, cardiac rehab can also be a good approach in balancing the benefit over the risk of these patients. Of course, if we have an ejection fraction which decrease quickly, no, by 5 to 10% after a cycle, or if um, the baseline ejection fraction is below 50, we cautiously secure the clearance of the cardiologist. In terms of liver, it's very, we also had a study in terms of transaminitis and also liver clearance prior to administering our systemic agents. And we found out that the increase in transaminitis can be slowly reversed with uh with the administration of the chemotherapy, as long as there are hepatoprotectants, no, such as your milk thistle, your uh, ursodeoxycholic acid, and also your vitamin E. So basically improving, it's really preparing the patient for expected side effect monitoring. So we need to work with our partner specialist to optimize the heart and the liver before administering good quality anti-HER2 medicines.
Thank you so much for the comprehensive answer. We have another question here. Good morning, Dr. Luna. For patients with ER+1, PR+1, and HER2+2 with no access to perform uh, FISH, what approach can we take to determine their complementary treatment? Thank you.
This is a very good question because we need those information in order to properly select the treatment. I could think of if there's no accessibility to fish, we could think of how about there are those agencies willing to accept their um, blocks and slides for review, such as partners with Global Cancer Center. They are willing to, if we send it to them, they could do some runs uh, for free under the GCI program. But I think this might be a little bit more challenging because the cost of transport might be shouldered by the patient, no? But there could be access programs which could help determine such an important test result. Mhm. Um, May I also ask if it's also a practice to have another second uh, consult or reading on the IHC? Like, for instance, another slide review can be done just to check if the IHC is consistently HER2 2 plus, um, and it might change, like it might go 3 plus in another um service provider. So another recommendation will be a slide review, another slide review.
Okay, yes. Someone answered the answer is yes to that question. Dr. Luna, if it's needed, yes. Yeah.
So Dr.
All right, thank you for the answer. Yeah, sorry.
Dr. Agus asked, they have already
Yes.
HER2 in Indonesia, but not affordable for almost patients. You only have trastuzumab, then Tykerb, in the national insurance. In the Philippines, is there any national health insurance covering for all patients? So it's very restrictive here in the Philippines. We do have our Department of Health, Health Technology Assessment Council evaluating these molecules. As of now, chemotherapeutic agents, trastuzumab as well as rituximab are the only approved in the Philippine National Formulary, which can be covered by the National Health Insurance. For some, they like Enhertu, it's not yet covered. It is currently under evaluation and in process for inclusion in the National Philippine Health Formulary. There's this question on HER2 breast cancer cells tend to spread to the brain mets. In your experience, is there any benefit to give ADC rather than conventional trastuzumab in this condition? Yes. So basically, it's more of the size of the molecule, and in addition, the mechanism of action of ADCs clearly showed intracranial activity compared with chemotherapy in most of the trials um, discussed a while ago. In prior or historical HER2 approach, I think it's a regional approach that they give intrathecal HER2, which is not a standard approach in our guidelines, but the clinical evidence is very much palpable when you administer ADCs for brain metastasis. They're at least 50-60% intracranial ORR, overall response rate, whether you give it in stable or treated brain metastasis over the or even with active brain metastasis, treatment naive. So it's gonna be a promising medicine, the ADCs. We should all be familiarized with the side effects, and it's gonna be a danger.
Thank you, Dr. Luna. And we have another question. Oh, I think this one is answered. What is the next treatment step if HER2 targeted therapy stops working?
This is the trastuzumab. Is it correct? All right. So what is the next step when the first line of treatment with HER2 positive or with HER2 positive disease stops working with trastuzumab. So safe to do some rebiopsy, no? So some biomarkers might be found as co-mutations. That's an option. But in HER2 space, you have the second line of treatment options documented to have clear benefit in the second line setting, such as your tucatinib, capecitabine, trastuzumab, and also your trastuzumab deruxtecan uh, after your your trastuzumab plus minus pertuzumab administration in the first line setting.
Thank you so much. And there is another question, doctor. What are the common side effects of HER2 targeted therapies and how can they be managed effectively?
All right. So for your ADCs, they are commonly nausea in most types of cases. The serious AEs would include your ILDs, pneumonitis, interstitial lung disease, pneumonitis. ILDs pneumonitis are best handled by a multidisciplinary approach by simple education with your patient. You tell them if you have dyspnea, difficulty of breathing, if you have some sort of chest discomfort inside, no? So as well as coughing, you just check it with pulse oximeter if the O2 saturation is okay or not. Then you need to be with high suspicion among these patients with your ADCs and quickly do imaging tests such as your high quality CT scans over the chest to determine if there's presence of your ILDs. In general, most of the treatment for this would be number one, discontinuation, interruption, drug interruption, serious AEs, discontinuation, as well as corticosteroids treatment. And of course, serial monitoring of symptom improvement is very much warranted.
Thank you so much for the answer. For the audience, please use the raised hand feature or the chat box if you have further questions. If not, then thank you so much, Dr. Luna. We really enjoyed the presentation. Thank you for answering our questions. And a reminder for the audience, don't forget to fill in the attendance form shared in the chat box. All right, thank you so much, Dr. Luna, for
Thank you
your
very much.
time. Next, let me introduce the next speaker for our second session, Dr. Agus Jati Sunggoro, a distinguished expert in internal medicine, hematology, and oncology. Here are some highlights of his exceptional background. Subspecialty expertise. Dr. Agus holds a subspecialist degree in hematology and medical oncology from Gajah Mada University, equipping him with advanced expertise in cancer treatment. Academic leadership. He serves as a lecturer and consultant in the Department of Internal Medicine at 11 Maret University and Muardi Hospital, Indonesia, contributing significantly to medical education and clinical practice. Global recognition. Dr. Agus has been invited to present his research at international conferences, including ESMO Asia Congress. Focus on breast cancer. He has completed specialized courses in breast cancer at ESMO, and his research on factors influencing chemotherapy delays in breast cancer patients highlights his dedication to improving outcomes in this field. Published research. His publications include works on hematological malignancies, cancer-related sepsis, and treatment outcomes in breast cancer. Today, Dr. Agus will share his insights on enhancing survival in advanced triple negative breast cancer, TNBC. Please join me in welcoming Dr. Agus.
Hello, good morning, all the participants and Ms. Mega Vati.
Morning.
To the admin, this is my slide. In this topic, I want to explain about, please section, enhancing the survival in advanced triple negative breast cancer. Please slide. This is my disclosure. I have no financial disclosure. Slide. Okay. In this news, we have to know that in a cancer management, we have to overcome the cancer management with multidisciplinary team. Slide. Like I make it that breast cancer like a Thanos there, and the multidisciplinary team is like Avengers that we can do the together to complete the management of the breast cancer. Slide. This is the concept of the multidisciplinary team that we have a medical oncologist, we have a surgical oncologist, we have a breast nurse, we have a physiotherapist, and we have a radiologist and nuclear medicine and also radiotherapist. We work together to overcome the breast cancer patient. Right? This is the objective of my presentation. There was an unmet need in the triple negative breast cancer. And the first presentation objective of my presentation is to give understanding the clinical course of triple negative breast cancer. And we have to understand the biological hypothesis and the classification and risk stratification of triple negative breast cancer. And we have to know the critical analysis and therapeutic strategies in the triple negative breast cancer. Slide. The key point in a metastatic triple negative breast cancer is not all metastatic triple negative breast cancer are created equal, because there is so many histology of triple negative breast cancer. There's the de novo triple negative breast cancer versus early relapse of triple negative breast cancer and heavily pretreated after the first line treatment of triple negative breast cancer. And finally, we have a biomarker to guide us to the treatment of triple negative breast cancer. There are two biomarkers, the PD-L1 and the germline or somatic BRCA mutation. And the best treatment is still to prevent the metastatic TNBC with aggressive and timely treatment of early stage TNBC. Slide. TNBC or triple negative breast cancer associated with early relapse. And the time to distant recurrence is approximately 2.4 years for the TNBC. And this is shorter compared with the ER positive patient that the time to the distant recurrence is 4.4 years. And almost of the TNBC have early recurrence. This is 54% of patients have a recurrence below 12 months, and the late recurrence is only 46%. Right? This is the comparing the epidemiology of the four type of breast cancer comparing to TNBC. We know that the risk of recurrence of the TNBC is higher, and the TNBC have the shorter survival comparing to the luminal breast cancer that the survival is almost 40 months. The TNBC is 15 or 14 months. And why this is why? Because in TNBC we have a lack of actionable driver mutation, and there is no established target molecular target. Slide. Metastatic TNBC have a biology and heterogeneity, and triple negative breast cancer is pragmatically named because of the absence of ER negative and HER2 negative. About TNBC is about 10 until 15% of all breast cancer and more common in younger women and enriched in germline BRCA mutation variant. And TNBC defines an unmet need because of aggressive biology resulting in the worst prognosis both in the early and metastatic setting. In this Kaplan-Meier curve, we have know that the survival of TNBC is lower than the other type of breast cancer. Right? We have that in the TNBC is more proliferative than grade 2 or grade 3 biology and high Ki67 and the definition of TNBC is ER negative below 1%, PR negative below 1%, and HER2 negative. Mostly abductal invasive, but there are some special histologies that need a special attention, like a metaplastic and the medullary and the myoepithelial carcinoma. Slide. There's molecular subtyping of TNBC. There is 4 subtyping. The first is basal-like immunoactivated. This is high of TP53 mutation and the complex genomic profile. And the second is basal-like immunosuppressed, that lower genomic complexity and activated on the PI3K pathway. And the third is mesenchymal, and the fourth is luminal androgen receptors. Slide. We know that in the TNBC, breast cancer is less immune activated than any other tumors. Why we have somatic mutation frequency in breast cancer in center, unlike with melanoma. Melanoma is have a somatic mutation, the high somatic mutation. So immunotherapy is very effective in melanoma patient. But in breast cancer, we have to check the PD-L1 immunohistochemia and combine the immunotherapy with chemotherapy in the TNBC. Slide. In TNBC, compared to other breast cancer subtype, the TNBC is characterized by higher PD-L1 expression, higher the T-cell infiltration, and higher the tumor mutational burden. So this is the impact that's the subtype of this TNBC. We can give the patient with TNBC with immunotherapy. Right? This is the biology and heterogeneity, that the immune activation is decreased in the metastatic disease compared to the early disease. In the early disease, the immune activation is high, and then in a heavily pretreated or metastatic TNBC, the immune activation is decreased. Slide. This is the therapeutic algorithm when we have a newly diagnosed or recurrent metastatic breast cancer. The first is we have to re-biopsy or biopsy of the metastatic lesion to confirm the diagnosis. Because for the first biopsy for the recurrence, there's some kind of different biology. So we have to reassess with biomarker like estrogen receptor, progesterone receptor, and HER2 receptors. And for patient with TNBC, we have to check the PD-L1 by immunohistochemia and BRCA mutation germline to guide us which is the best treatment for the patient. Slide. This is the NCCN and the ESMO guideline that recommend that if we have a recurrent or metastatic breast cancer, we have to diagnose and we have a right biopsy to confirm the histology and to the reassess of the tumor biology. And if we have the TNBC, we have to check the germline BRCA and the PD-L1 status in TNBC. Slide. What side should we test the PD-L1? This research tells us that the comparison of PD-L1 protein expression between primary tumor and metastatic lesion in TNBC, and the PD-L1 higher in the metastatic lesion, higher in the primary beside of the metastatic lesion, and the lower positivity rates is in the liver in the skin and the bones, right? This graphic shows us that PD-L1 status in the primary versus metastatic tissue, and this tell us that PD-L1 status is higher in the primary tissue compared with the metastatic tissue, and the PD-L1 status is higher in the lymph nodes, and then lower in the liver and the bone, right? This is the algorithm how we choose the treatment for the patient with metastatic TNBC. The first, we have to search therapeutic marker. The biomarkers, like I said before, that we have to check the PD-L1 receptor or PD-L1 by immunohistochemia. And the second is the BRCA mutation by germline or somatic BRCA mutation. If the PD-L1 is positive, then we can give the patient with immunotherapy combined with chemo. This is atezo and pembrolizumab combined with chemotherapy. If we have a germline BRCA positive, if the patient have access to PARP inhibitor, give the PARP inhibitor. If the patient have no access to the PARP inhibitor, in the germline BRCA, chemotherapy based with platinum, which is carboplatin, is better than avotaxan. In the PD-L1 negative and germline BRCA wild type, we have to give the patient a chemotherapy. Slide. Now we have to discuss about the immunotherapy. Immunotherapy, like I said before, is have more activity in a triple negative breast cancer, because in the triple negative breast cancer have a higher tumor mutational burden and higher PD-L1 status. And this PD-L1 blocker, which is the drug is pembrolizumab, is ligand blockade to inhibit the PD-1 and PD-L1 to connect. And then if they are blocked, that the cytotoxic T cell is activated. So the cytotoxic T cell is activated and have to tie the tumor cell, right? This is different with the chemotherapy, right? In a chemotherapy, mainly target that activating proliferating by inhibiting cell division. In the immunotherapy, we have to block the ligand of PD-1 and PD-L1 and then enhance the T cell. Slide. This is three trial in the immunotherapy in the metastatic triple negative breast cancer. The first one is impatient 130, and the second is impatient 131, and the third is KNOT 355. And the positive trial is impatient 130 and KNOT 355. That this is the use of atezo plus nab-paclitaxel and the pembrolizumab plus chemotherapy. Slide. This is the study design of impatient 130, that the key eligibility criteria is heterological TNBC, no prior treatment for advanced TNBC, the ECOG 1 or 0, and eligible for taxane monotherapy and PD-L1 testing. This is randomized double-blind. One give the atezo plus nab-paclitaxel, and the second arm is placebo from nab-paclitaxel. And the primary endpoint is PFS and OS, right? This is the result that atezolizumab plus nab-paclitaxel have the 3 years overall survival 36% compared with the placebo 22%. And the hazard ratio is 0.67. This is significant. So it's prolonged the survival of patient with TNBC in the PD-L1 positive. Slide. This is the impatient 131, but this is a negative trial because of the hazard ratio is and the P is not significant. Slide. This is the third study, that the positive trial, the KEYNOTE 355, that we use pembrolizumab Keytruda, and then the chemotherapy and the placebo. The second arm is placebo plus chemotherapy. There is 3 types of chemotherapy. This is paclitaxel weekly, 90 milligram per meter square, and the nab-paclitaxel weekly, 100 milligram per meter square, or gem carboplatin. Slide. This is the different chemotherapy regimen in this trial. Slide. And this is the baseline characteristic. That's almost all patients have more than 12 months disease-free intervals, and most of the patients have the chemo with gem and carboplatin. Slide. This is the result. The result is the median overall survival is 23 months with patient with pembrolizumab plus chemo. Compare with the placebo plus chemo is just 16 months. And this is reduced 27% risk of death. Slide. So we have compared three trial. The positive trial is impatient 130, and the second one is Keynote 355. That's in the Keynote 355, the median overall survival in 23 months, and the impatient 130 is 25 months. Okay, slide. Oh, when we use the IO or immunotherapy, we have a toxicity that differs from the chemo. The toxicity is called immune-mediated adverse events. There's in the three trial, the grade 3 adverse event, immune-mediated adverse events, if in the Keynote 355 is 5.2%, and higher in the inpatient 130 is 9%. What type and slide? Toxicity with IO or immune checkpoint inhibitor is timing can be high variable. Immune-mediated adverse events occurs can occur in months or even in years. And we can know that the incidence of RAS is in the early months of the treatment. There's patient that colitis, diarrhea, and the high of hepatitis autoimmune in the liver, and pneumonitis in the late months. Slide. We have to manage the immune-mediated adverse event by multidisciplinary management coordinated by the oncologist. We have to coordinate with pulmonologists, gastroenterologists if there is a colitis, ophthalmologist if there is a rhinitis, the other subspecialists like rheumatologists, cardiologists. Then we have to talk to our friends of subspecialists to treat this immune-mediated related adverse event. Slide. So in the patient with metastatic TNBC, if we have the PD-L1 positive, based on the two trial, that positive trial, that Keynote 355 or M-patient 130, we have to give the patient with IO plus chemo. We can choose the atezo plus nab-paclitaxel, or in the Keynote 355 is pembrolizumab plus chemo. Okay, slide. And what's next for this patient, right? A lot of unanswered question in use of immuno-oncology IO or immunotherapy. How many cycle? That's the chemo we do have get to give before shifting to maintenance IO. Or for patient with long benefit to maintenance IO, could we switch to the lower dose to lengthen the schedule? Or how best to identify the benefit of EO? The PD-L1, which assay? It is which metastatic site we have to assign the PD-L1. Have we have to check the tumor microenvironment border, or we have to get the best biomarker, a better biomarker to give the patient the best benefit. And the last is we have to care the toxicity of IO, the immune-mediated adverse event, by multidisciplinary team. Slide. The second is how the chemotherapy option in the PD-L1 negative and wild type gamelan BRCA. So the right side slide. For patient with metastatic TNBC, sequential single agent chemo is the preferred approach. So you can use Taxan, is paclitaxel or docetaxel. You can use the anthracycline based doxorubicin or apirubicin. You can give the antimetabolic capecitabine, or you can give other that eribulin or again that carboplatin. It's the same survival benefit. Slide. How about in the patient with germline BRCA mutation positive with NBC? There is two options. If patient have the access to PARP inhibitor, give the PARP inhibitor. If patient do not have PARP inhibitor, they have access to PARP inhibitor, you can give the chemotherapy, but the platinum is the best for the germline BRCA mutation. Slide. This is the TNT trial, that carboplatin versus docetaxel in the advanced TNBC or BRCA mutation. There are 376 patients. There are two arms, carboplatin, 6 cycle or docetaxel. Slide. And this is the response rate that in the patient with BRCA mutation, in the pink tab, that and if the response rate is higher if we use the carboplatin. So patient with the BRCA mutation, you should give the carboplatin for the patient. Slide. And if patient have the access to PARP inhibitor, there is two regimen, olaparib or talazoparib. Olaparib in the trial of Olympia trial and talazoparib in EMBRACA trial. Slide. This is slide, please. In the metastatic setting, olaparib and talazoparib provides the option to germline BRCA patient TNBC that the median progression survival is higher than the 8.6 months in talazoparib, and the olaparib is 7 months. Right? This is the comparable. What we use first in the germline BRCA positive, PARP inhibitor plus or platinum first chemotherapy. The PFS is the same, 7 months in Olympiad. EMBRACA trial talazoparib is 6 months, and the chemotherapy with carboplatin is 6 months. So there is no head-to-head comparison between them. So no overall survival benefit advantage. So the issue is the cost and quality of life. So if the patient have access to PARP inhibitor, give PARP inhibitor. If patient do not have access because of the cost, so give the chemo with carboplatin. Slide. Slide. So what's next for the patient with triple negative breast cancer? Slide. Said the Dr. Luna said that we have that in the ABC5 patient with low ER, the definition of low ER is the estrogen receptor 1 until 9% is considered as patient with triple negative. So a lot of doctors give hormonal therapy like tamoxifen, or in postmenopausal give aromatase inhibitor in with patient with low ER, but it's don't have a benefit. So if you have patient with low ER with 1 until 9%, consider as a triple negative, right? The second one is the prevalence of HER2 low. We know that in HER2 immunohistochemia, that's immunohistochemistry, HER2 definition positive is the scoring if 3 positive. If you have a 2 positive or 1 positive, you have to check the FIS or CHIS. If the FIS or CHIS is positive, this is you call the patient HER2 positive. If you have the patient with immunohistochemistry a positive 1 or positive 2, but FIS or CHIS are negative, you can call the patient if HER2 low. So the patient with HER2 low slide is some about 60 or 65%. And like Dr. Luna said that HER2 ultra low also 20 and 25%. This patient, this subgroup of patient have benefit with the ADC, the Enhertu, trastuzumab deruxtecan, TDXD. Slide. And the second one is the TROP2 expression. There is high TROP2 expression in metastatic TNBC, in a HER2, in the TNBC and hormone receptor positive, HER2 negative, that TROP2 expressed in almost 96% in patient with TNBC. So the high TROP2 expression suggests that pre-therapy biomarker assessment is not required. So the patient can give the anti-TROP ADC slide. This is the anti-TROP directed ADC, a TROP2 directed ADC. There is 3 drugs: sakituzumab govitecan, dabotamab deruxtecan, and sakituzumab deruxtecan. Okay, slide. So it is the last of my slide. Then, if we have the metastatic TNBC, for the first line, we have to check the PD-L1 status. And then we have to check the Guillain-Barré. If the patient have the PD-L1 positive, give chemo plus immunotherapy. You can give pembro or atezo. If the PD-L1 negative patient, if the BRCA mutation positive, give the olaparib is accessible or talazoparib. If not accessible, give platinum. In the other hand, if the Guillain-Barré is negative or PD-L1 is negative, give sequential chemo. Or how about the second line? In the second line, you can use sakituzumab govitecan, TDXD. You have to check is the patient HER2 low, or you can give the taxane. And the third line, there have to so many treatment that sakituzumab govitecan, TDXD, olaparib, or talazoparib, or just chemotherapy, a single agent. Or we have to check the other biomarker. Is there the tumor mutational burden, MSA hive, or DMMR, and TRAC mutation, RAT mutation. And we have to consider NGS in the patient to check the biomarker. Slide. Then the summary of my presentation is one slide. Next, if we have the patient in the next Monday morning, if patient have a metastatic TNBC, first is if we can get the right biopsy, code the right biopsy of the metastatic, and the check, reassess the ER, PR, and HER2. And if the patient is triple negative, check the PD-L1 and Guillain-Barré. And then we have to know that the definition of TNBC is this more spread, that the ER low, the ER positive 1% or until 9% is considered TNBC. So we can consider the treatment of TNBC. Slide. This is the treatment algorithm I said before. Slide. And what's it the next in the metastatic TNBC? Slide. The first is, can we challenge immunotherapy after immunotherapy given in the first line? Should patient with ER low, HER2 negative disease offered by immunotherapy because ER low considers of TNBC? And what is the optimal duration of chemo in patient with combination with immunotherapy? And should immunotherapy continue under progressive disease? And how to treat the early relapse? Slide. Thank you for your attention, and we have to time to question and answer. Thank you.
Thank you so much, Dr. Agus, for the insightful presentation. We will now proceed to the discussion session. Please use the raised hand feature or the chat box to ask your questions. In the meantime, we already have some questions here. So, Dr. Agus, this is the question from Dr. Debbie. We know that TNBC is the most chemotherapy sensitive molecular subtype of breast cancer, with almost 23% of patients receiving platinum-based treatment, achieving a complete pathological response. Under what conditions should we consider transitioning the therapy to targeted therapy? Thank you.
Okay, Dr. David, thank you for the question. The first is, what is the stage of this TNBC? Is this early TNBC or metastatic TNBC? In the early TNBC, we have the guideline that said that if the tumor is more than 2 centimeter, we have to give neoadjuvant chemotherapy. What kind of neoadjuvant chemotherapy is best? The PD-L1. If the PD-L1 positive, we have to give the immuno plus chemotherapy. Immunotherapy in the neoadjuvant setting is proof that it's a better pathological complete response. If you have said that 23% using platinum is pathologic complete response, but it is the subtype of the germline mutation TNBC. So not all TNBC. If the patient have recorded that patient germline mutant, you can give the platinum. But if you have no recorded patient germline mutant patient in the early setting, you have to check the PD-L1 status, and the PD-L1 status is positive. You have to give the chemotherapy with immunotherapy, pembrolizumab plus chemo. The chemotherapy regimen is 4 cycle of paclitaxel carboplatin plus 4 cycle anthracycline and cyclophosphamide. And what condition we start to targeted therapy? In the condition of the metastatic disease. In the condition of metastatic disease, we have to change the converted therapy based off the biomarker. I said before there is 2 biomarkers. The first is PD-L1. The second is BRCA mutation. If the PD-L1 positive, you have to give the immunotherapy. If the germline BRCA positive, you can give the targeted therapy PARP inhibitor if accessible. If not accessible, like I said before, that germline BRCA mutation sensitive with platinum agent, so give the patient platinum agent chemotherapy. What about if the PD-L1 negative and the germline BRCA is negative? I just give the patient with sequential chemotherapy. There is no head-to-head comparison with of the chemotherapy. You can give the patient with taxane. You can give the patient with eribulin or something like that. The median progression-free survival is very short, maybe 7 to 9 months, because the TNBC is very bad prognosis, different with the other type of breast cancer. Thank you.
Thank you so much, Dr. Agus, for the comprehensive answer. We have another question here. This topic discusses many chemotherapy regimens. How about in cases of hormone-dependent breast cancer, such as breast cancer combined with endometrial cancer? Can these chemotherapy regimens be used, or should treatment be limited to hormonal therapy only? Do you have any data on the combination of multiple chemotherapy regimens and hormonal therapy? Thank you.
Okay. If you said that this patient have the two condition. There is two malignancy of the patient, the breast cancer, and the second is endometrial cancer. So we have to check, is this two disease or one disease that's metastatic to the endometrium. We have to check. By second opinion to the pathology, we have to check the immunohistochemistry, and based what I read before, there is no data combined therapy chemo plus hormonal. So in the patient with breast cancer or endometrial cancer, you give chemo first. You give chemo first in the metastatic setting. In the early setting, the surgery is the first treatment. In the metastatic setting, you give the chemo first, and then you followed by the hormonal therapy. If the estrogen receptor is positive, you can give the hormonal treatment for also to the endometrial cancer. But the first ones, if you have to conclude this is a one single disease or this is a two disease in the patient. So you have to conclude that and check all the patient CT scan or whole body PET scan, what is the metastatic site, and then reassess the biopsy of the metastatic site. Is this from the breast cancer or is this from the endometrial cancer? So it's a little bit complex. So it's need a multidisciplinary team to discuss what is the best treatment for the patient. Thank you.
Thank you so much, Dr. Agus, for the answer. We have another question here from Dr. Luna. Hi, Dr. Agus. Thank you for your presentation. Do you think germline BRCA and PDL1 testing should be included in the initial breast panel alongside ER, PR, HER2, and Ki-67 in the future?
Okay, thank you, Dr. Herdi Luna, for the question. What I said is, in the future, maybe germline BRCA and PDL1 testing should be the part of the initial breast cancer panel if the patient is triple negative. Not all the patient of breast cancer. If the triple negative, you have to check germline BRCA in the early setting and the PDL1 in the early setting to get the chance of what is the best neoadjuvant treatment for the patient in the early settings. So, beside that, in the early setting of patient with young woman under 40 years old that have a breast cancer, we have to inform that's the risk of BRCA mutation. So we offer the young woman with the breast cancer under 40 to check the BRCA mutation. And this is correlate with the question for Mahindra that in the patient with BRCA mutation positive, the risk of inherited to the boys or girl of the son is 40%, the chance of inherited BRCA mutation. As you have know that the if we have the young patient and then the BRCA mutation is positive, we have to check also the son if there is a BRCA mutation germline positive in the son. Okay, thank you.
Thank you so much, Dr. Agus, for the answer. We have another question here from Nurse Mahindra. May I ask if a TNBC patient has a BRCA mutation, does it increase the risk of cancer in her children, both boys and girls? And what screening examinations would you recommend for her children?
Okay, thank you. The test of the BRCA mutation is popular because of the artist Angelina Jolie. The mother of Angelina Jolie have the BRCA mutation positive. And then Angelina Jolie checked the blood and checked the BRCA mutation. And the Angelina Jolie have the positive BRCA mutation. What guidelines says in this setting? In the woman with BRCA mutation positive, we have to check screening with breast MRI annually. And Angelina Jolie take the other step that she get double mastectomy as a prophylactic. Double mastectomy as prophylactic. This is the most prophylactic because there is no cancer, but Angelina Jolie do double mastectomy because she's BRCA positive. Correlate with this question, what is the advanced screening examination for her child? Because the child is maybe under 10 years old, maybe the screening is we have to check if the patient, the sons, the girls in maybe 20 or 30 years annually breast cancer screening with sadari, periksa payudara sendiri, or the best is for breast MRI. Thank you.
Thank you, Dr. Agus. And we have another question here. What are the latest advancements in immunotherapy for advanced TNBC, and how do they impact patient survival?
Oh yeah, we have like I said before on my slide that there is two trial, inpatient 130 and the second is Keynote 355. The use of combination immunotherapy plus chemotherapy prolong the survival. The median overall survival nearly 23 or 25 months. And the other hand, the placebo is only 16 or 17. So the use of immunotherapy is prolong the survival in metastatic TNBC, but in the subtype of PD-L1 positive. So we have to check with immunohistochemistry the block of the specimen of the patient to check the PD-L1 status. If the PD-L1 status is positive, more than 10% or more than 5% in the patient 130, we have to give the patient combination chemotherapy and immunotherapy.
Thank you so much for the answer. And we have another question here. How do you decide between chemotherapy alone and the combination therapies in managing advanced TNBC?
Okay. When we give the patient sequential single agent, or we give the patient with double chemotherapy. I said this in the setting of patient with PD-L1 negative and in the setting of germline BRCA negative. So in the patient with TNBC with PD-L1 negative or germline BRCA negative, we have to choose the chemotherapy. When we use the single or double chemo, the first is the patient performance status. If the patient performance status is good, you can give the patient double. If there is organ imminence failure, like patient have a liver metastatic or pulmonary metastatic with Jepsio, if the performance status is good, you can give double drug if the performance status is good. But I recommend to give sequential single agent. Why? Because we have to manage the toxicity of chemo to the patient. if you give the two drugs, maybe so many adverse event will occur. So we can know the patient can survive or not. So I suggest we use sequential single agent. Okay, thank you.
Thank you. And our next question is, are there specific biomarkers that can guide treatment selection and improve outcomes in advanced TNBC?
Yes, there is two biomarker. The first is PDL1 status. PDL1 is we have to check the specimen of the biopsy to the pathologist to check immunohistochemistry. If it's the PDL1 is positive, we can give them immunotherapy. The second biomarker is BRCA mutation. BRCA mutation can check two type of check: the germline BRCA mutation and the somatic BRCA mutation. The germline BRCA mutation is the check drawn by the blood, draw the blood of the patient and check there is if there are any pathologic mutation. This is called germline BRCA. The second one is somatic BRCA mutation. Somatic BRCA mutation is checked from the biopsy of the patient. From the biopsy, you can check the patient sample and send to the laboratory to take the PCR if there is any variable pathologic mutation. So there is two type: PD-L1 status and BRCA. BRCA mutation is have two: the germline BRCA drawn by the blood, or the somatic is from the sample biopsy. Thank you.
Thank you so much, Dr. Agus, for the answer. And for our participants, please use the raise hand feature or the chat box to ask questions if you have further questions for Dr. Agus. If not, then thank you so much, Dr. Agus, for the
Thank you so much,
presentation and for answering our
Bupati.
questions.
Okay.
Thank you. So for participants, don't forget to fill in the attendance form shared in the chat box. All right, next, let me introduce our third speaker from this session, Dr. Din Thi Lan An. Good morning, Dr. Din Thi Lan An.
Hello, everyone. Hello, everyone.
Thank you so much. Yes, we can hear you clearly. Thank you so much for coming to our webinar.
Yeah, thank you so much for having me today. I'm trying my best to change my background, but I could not. I don't know why. So,
All right. So, I would like to introduce Dr. Dien Thi Lan An. I hope that I pronounced your name correctly.
yeah,
An
yeah,
accomplished.
yeah.
Yeah.
Everything is okay.
Okay, thank you so much. So, Dr. Dien Thi Lan An is an accomplished oncologist with an extensive background in the treatment of lung cancer and other advanced malignancies. Here are some highlights of her exceptional qualifications. The specialized expertise. Dr. Lan An completed her advanced training in oncology at Hanoi Medical University and has further specialized in clinical trials and innovative cancer treatments at prestigious institutions, including the Institut Curie in France and the Royal Marsden Hospital in the UK. Focused research. Her published works include groundbreaking studies on HER2-positive breast cancer and targeted therapies for non-small cell lung cancer. Global recognition. Dr. Lan An is a recipient of multiple awards, including the ESMO Leaders Generation Program and the Japanese Society of Medical Oncology Rising Stars Award, highlighting her global impact on cancer research. Clinical leadership as a senior oncologist at Vietnam National Cancer Hospital. She leads clinical trials and mentors young oncologists advancing oncology care in Vietnam and beyond. Today, she will share her expertise on current treatment strategies for EGFR mutated non-small cell lung cancer. Please join me in welcoming Dr. Lan An.
Thank you for your introduction. Hello, everyone. My name's Anh Đình. You can call my by Anh or Đình. It's okay for me. I'm so happy to it's honor for me to be here, and thank you all of you for having me today. Today my topic, let me say. Let me share my screen. Could you see my screen?
Not yet, doctor.
Oh my God. Sorry.
In the meantime, for participants, please don't forget to fill in the attendance form shared in the chat box. Dr. Ant, do you want us to help you with the showing the presentation? We can assist with that.
Oh, wait for me, please.
All right.
So sorry because there's something wrong with my computer.
Yeah,
So,
no worries.
yeah. So could you see my screen?
Yes, we can see your screen. The floor is yours. Thank you.
This is my topic. Current treatment strategy for the EGFR mutation. And this is my disclosure. At first, as you see, over the past 30 years, we have a significant advancement in lung cancer treatment. Initially, lung cancer was considered a single disease. It was later characterized into two groups, small cell lung cancer and non-small cell lung cancer. Subsequently, non-small cell lung cancer, which are caused for the to 85% of lung cancers, was further subdivided based on histological features into small squamous cell carcinoma and non-SCC. With advancement in molecular biology, non-small cell lung cancer was further divided into two groups, those with drive mutation and those without. This classification allows for personalized treatment approach. Today in my presentation, I will focus on patients with drive mutations, especially EGFR mutations. This mutation is highly prevalent in Asian patients, you see, with a prevalence ranging from 30 to 50%. And EGFR mutation, EGFR is a transmembrane protein, consists with an extracellular domain, transmembrane domain, and an intracellular domain. EGFR gene mutation commonly occurs in exon 18 to 21, with mutation at exon 19 and 21 mutation. Though accounting for up to 90% of the the EGFR mutation in exon 21 is a resistant mutation to the first and second generation TKI. Currently, there are three generations of EGFR TKIs. The first generation includes erlotinib, zotifenib, and the second generation consists of afatinib, dacomitinib, while the third generation includes osimertinib, lazertinib. Lung cancer patients with the EGFR gene mutation can benefit from TKIs, and the treatment strategy using TKIs varies depending on the state of the disease and treatment goals. Today, I will focus on advanced and metastatic stage first, and then the early stage will be discussed later. For the patient with the advanced and metastatic disease, monotherapy or combination therapy with the TKIs is preferred. Referred as first-line treatment according to the clinical practice guideline from NCCN or ESMO guideline. Let's divide into the efficacy and application of TKIs in more details. At first, we will discuss the first generation TKI like erlotinib and zotifenib. These drugs were the first study in non-small cell lung cancer in 2005. It's important to note that the concept of EGFR mutation was not widely understood at that time. The results show no significant difference in the efficacy compared to placebo. Fortunately, shortly after, Thomas Link discussed EGFR mutation in a small subset of patients who exhibit a remarkable response for the first generation TKI in the previous study. And then soon after that, in 2018, the IPAS study was conducted in non-small cell lung cancer. In this study, the compared efficacy of zotifenib and chemotherapy, which is the paclitaxel and carboplatin. The results IPOS study demonstrates no significant difference in overall survival between zoliflodacin and chemotherapy in all of the patient population. However, subgroup analysis based on EGFR mutation status reveal a significant improvement in a progression-free survival (PFS) with zoliflodacin in the patient with EGFR mutations. Conversely, chemotherapy was more effectively than zoliflodacin in the patient without EGFR mutation. Following the success of IPAS, several other Asia countries conduct a similar study to confirm the efficacy of zoliflodacin in EGFR mutation patients. This study consistently demonstrates a PFS benefits of 9 to 11 months with zoliflodacin in EGFR mutation patients. Concurrently, studies that are optimal and OTAC evaluate the efficacy of elotilip showing survival benefit in EGFR mutation lung cancer patients. So, which generation should we priority in the clinical practice? To answer this question, Chinese research conducted the CETON study to compare the efficacy of elotinib and zoliflodacin. The results show that no significant difference in the PFS and OS between two groups. The choice in the clinical practice depends on the clinician experience. Next, we have second generation TKI such as afatinib, which has demonstrates efficacy in EGFR mutation patients in two studies, LUC-Lung3 and LUC-Lung6. These two studies has a similar design with two arms, one treated with afatinib and the other treated afatinib and the other with chemotherapy. The difference was that LUC-Lung3 was conducted in non-small cell lung cancer patients, while LUC-Lung6 was conducted in the patient with squamous cell lung cancer. The results of both studies were consistent, so the median PFS improvement up to 11 months with the afatinib compared to just 6 or 7 months with chemo. However, overall survival did not improve, similar to previous study with the first generation before. The study showed that achievement with in the 2021, a subsequent study on dacomitinib, a second generation TKI, was published. Notably, this study directly compared dacomitinib with zoliflodacin. That is a first generation TKI. The results show that achievement with dacomitinib improved both PFS and OS compared to zoliflodacin. However, patients treated with dacomitinib experience a significant higher rate of adverse events and serious adverse events up to 22% of patients discontinue treatment and 66% require dose reduction. Dacomitinib is currently not available in Vietnam for what it was, you see. Afatinib also was compared to zoliflodacin in LUC-Lung7 study. Although both groups show the similar PFS benefits of approximately 11 months, afatinib also demonstrates a longer duration of response. there was no difference in PFS between two drugs when analyzed by EGFR mutation status, such as exon 19 or 80 or 21 mutation. Overall survival did not improve for either group, regardless of subgroup analysis. And once again, the study indicates that treatment with second generation TKI lead to more advanced adverse events, particularly in diarrhea. While the first and second generation TKI have shown efficacy and improved quality of life for the advanced non-small cell lung cancer patient, most patients develop a resistance after 1 year of treatment, just 1 year. Many resistance mechanisms has been proposed, with the most common being the emergence of a resistant mutation, such as the T790M mutation. The advent of third generation TKIs has offered a new hope for our patients who develop acquired resistance after failing first and second generation TKI. This was demonstrated in Aura-3 study. In Aura-3 study, osimertinib, a third generation of TKI, was compared to chemo as a second-line treatment for the patient who has progression on the first and second generation. And how about the T790M resistant mutation? The result was remarkable, with the patient treated with osimertinib experienced PFS of 10 months significantly higher than 0.4 months observed in the chemo arm. Subsequently, osimertinib was rapidly approved as a second-line treatment for the patient with the T790M mutation after failure of first or second generation TKI. Building on the success of Aura-3, osimertinib was quickly studied as a first-line treatment in the Flora study, where it was compared to the first generation like erlotinib or zertinib in the patient with EGFR exon 19 or 21 mutation. The result was impressive, with osimertinib improved PFS in all patients and subgroups. Most notably, thus, osimertinib improved overall survival in anti-study population. However, it's important to note that subgroup analysis in Flora. So for us, that's no clear benefits for the other patients, although with the LS5 LS5SR mutation compared to first or second generation TKI. Significant advance of osimertinib is its ability to cross the blood-brain barrier, which increase progression-free survival without central nervous system involvement, and improve treatment outcome for the patient with brain metastasis. Treatment with osimertinib did not increase adverse event compared to the first and second generation TKIs, especially the skin-related adverse event and liver function, which are common side effects on the first and the second generation TKI. So there are many other EGFR mutation subgroups, including rare mutation and exon 21 mutation. What are the treatment strategy for this case? A subgroup analysis showed the efficacy of afatinib in the patient with a rare mutation like LS61Q or Z719H. Therefore, clinicians offer prioritize afatinib for the patients with the rare mutations. Additionally, osimertinib has also shown the benefits in the patient with a rare mutation, making it another option in clinical practice alongside afatinib. For the patient with exon 21 mutation, amivantamab is a dual targeting therapy that has demonstrates the efficacy. And mobocertinib is another option for the patient with the exon 21 mutation, particularly in China. Recently, both drugs has been studied in combined with the chemotherapy as the first line treatment for the patient with exon 20 mutations. However, only the amivantamab study was successful, and currently amivantamab combined with chemotherapy is preferred in the first line treatment for the patient with exon 21 mutation. TKI also has been extensively studied in the combination with other therapy to improve treatment outcome. For example, here we have some positive trial like EGFR TKI combined with anti-angiogenic agents, bevacizumab or ramucirumab, or chemo combined with EGFR TKI or TKIs combined. Currently, their combination therapy include from in a clinical practice guideline from NCCN or ESMO guideline. Therefore, for different EGFR TKI, EGFR mutation and clinical scenario, there are various treatment options based on TKIs. Now, we will move on to the second line treatment option for the patient who have a progression on the first line of TKIs. According to the ESMO guideline, patients who progression on the first line TKI should undergo repeat biopsy, include liquid biopsy or tissue biopsy to guide the second line of treatment selection. Both ESMO and NCCN guidelines provide recommendation for the second line treatment based on molecular marker and clinical context, and also resistance mechanism. Progressive disease characteristic vary, depend on the situation, local or system treatment can be selected. Since osimertinib is the common first-line treatment, ESMO has a specific guideline for the managing patients who have developed resistance to the osimertinib, but have no progress to receive systemic disease. Notably, in the most case, a combination of local treatment and continued osimertinib is recommended. For the patient with a progression systemic disease, repeat biopsy are crucial for the determine the appropriate second line treatment. The second group of our patient I would like to discuss is those who have undergone study for the patient in the early stage, from stage 1B to 3A. All patients continue treatment with osimertinib with or without chemotherapy is indicated. The ADAURA study has confirmed the efficacy of this approach. The study showed that adjuvant treatment with osimertinib in the patient with a stage 2 or 3 disease after surgery, improve the median disease-free survival to more than 60 months, although overall survival was not improved. And especially child for this year, the LAURA study was published. In this study, evaluates the efficacy of osimertinib in the stage 3 non-small cell lung cancer patient with EGFR mutation who has received a definitive chemoradiation therapy. And the result was remarkable with the osimertinib group shows PFS improvement of nearly 40 months, mean 6 times higher than placebo group. So in my conclusion, TKI for the first advanced non-small cell lung cancer, we have some common with the common mutation like 19 or 21 mutation. We have some TKI like first generation zotifenib, allotinib, or second generation afatinib, dacomitinib, or third generation osimertinib, nazatinib. Recently, some combination so improve the outcome for treatment patient with advanced non-small cell lung cancer with EGFR mutation. Afatinib and osimertinib are options for the EGFR rare mutation known as exon 20. Chemotherapy combined with amivantamab is the standard for the first line treatment EGFR mutation in exon 20. And osimertinib based in the first line treatment improve PFS and OS preferred for the brain met non-small cell lung cancer. Now, we should be keep many factors in consideration in choosing the second line after TKI's failure. TKI the generation 3 the generation indicate in the adjuvant non-small cell lung cancer EGFR mutation after surgery. And the first generation indicated in the adjuvant non-small cell lung cancer mutation after definitive chemoradiation therapy. Finally, thank you all of you for your attention. Thank you so much.
Thank you so much, Dr. An, for your amazing presentation. And for participants, we will now proceed to the discussion session. Please use the raise hand feature or the chat box to ask your questions. In the meantime, we already have some questions here from Dr. Debbie. Dr. Ant, in breast cancer, we have already concluded that early stages 1 and or 2 are curable, while advanced stages are only treatable, focusing on quality of life and prolonging survival. How is this perspective applied in the field of lung cancer?
Oh, yeah, for this question, I have to say that not only the breast cancer, but also not only breast cancer or lung cancer. In cancer treatment for January, we have set the target treatment before we decide the strategy for patient. Besides the treatment outcome, the quality of life for the patient is more important. And I have to say that in lung cancer, we also set the quality of life as the goals before decide the strategy for each patient depend on the personalized patient.
Thank you so much, Dr. Ann, for the answer. We have another question from Dr. Agus Jati. Dr. Ann, can we check EGFR mutations using blood, liquid biopsy? Which do you prefer, blood or tissue?
Depend on this about EGFR testing depend on the situation. In case the first time of diagnosis, we prefer to use the tissue for the test EGFR. It helps us also make sure about the histology molecular as also the other molecular testing like EGFR. Anyway, in the second line, in the second line scenario, depend on the clinical practice reality. In case the tissue biopsy is easier for the clinical to biopsy, we prefer to use the tissue for the biopsy and do some molecular tests to make sure there's no transform in histological and do some molecular testing also. In case it's difficult or not safe for the patient, we have used liquid biopsy depend on the reality clinical case.
Thank you so much, Dr. Ann, for the answer. We have another question here. What are the current approaches to managing resistance to EGFR targeted therapies such as osimertinib?
I'm so sorry. Could you repeat the question?
Yes. So, what are the current approaches to managing resistance to EGFR targeted therapies such as osimertinib?
And I have to say that this resistance for even the osimertinib quite effective for our patient, not only for the single agent but also the combination with the other agent. Recently, we have a large study to help patient overcome the resistance of osimertinib, like osimertinib combined with other agents like osimertinib combined with chemo or with other TKI. For the significant scenario, like patient have brain mass or patient have a double mutation, we will decide which combination will be should be combined with osimertinib to improve the efficacy of treatment for patient, so that patient get benefits from the third generation TKI inhibitor in optimal.
Thank you so much for the answer. Another question is from Dr. Agus. I have a metastatic NSCLC patient with PDL1 more than 50%. and an EGFR mutation, exon 19 deletion, what treatment would you suggest? Should I give TKI or single agent immunotherapy? Thank you.
I have to say that the number of patients, the percentage of patients who have both EGFR mutation and expression of PD-L1 not common anyway. For almost a study focused on immunotherapy, checkpoint inhibitor. On the subgroup, the patient who suffer from EGFR mutation did not improve overall the survival for the patient. I mean, for the patient who suffer from EGFR mutation, almost them may not receive the benefits of immunotherapy. So for this patient, in my opinion, we should use TKIs as the first choice for patients.
Thank you so much, Dr. Ann, for the answer. And we have our next question here. Are there specific factors that influence the choice between monotherapy and combination therapy in treating EGFR mutated non-small cell lung cancer?
I'm so sorry because there's something wrong in my computer, so I could not hear your voice clearly. So could you repeat the question?
Yes, sure. So the next question is, are there specific factors that influence the choice between monotherapy and combination therapy in treating EGFR mutated non-small cell lung cancer? Thank you.
Yeah. As my presentation, we have some strategy for combination between the TKI and other agents. And in fact, depend on the clinical practice of Asian countries like in Japan and India, they cannot use the TKI, the first generation TKI combined with bevacizumab as the first line treatment because of they have their own strategy on their population. And generally, for combination strategy, we should be used for patient with worse prognosis, like patient have a double mutation, or patient with the brain mass, the patient with other worst prognosis factors also.
Thank you so much for your answer. And we have another question here. How do you choose the best EGFR TKI for treating EGFR mutated non-small cell lung cancer?
So this is the reality our clinical practice because depend on the Asian countries. In Vietnam, we our government just cover for the first generation and other than generation TKI like the third. The second and the third, our government did not cover for the treatment, so patients have at first for those. I have to say that in depend on the patient patient at first ability and in case exclude the economy problem, we are keen on use the third generation for the patient with the exon 19 or 21. mutation at first. In case the patient have a rare mutation, we keen on use the second generation, and somewhat for patient who who have exon 20 mutation, we use chemotherapy for them, excluding some exon that is sensitive with TKI. I remember that we just one exon in 20, one mutation in exon 21 that is sensitive with the TKI. And in Vietnam, we have not approval for the combination between TKI and other agents.
Thank you so much for the answer. We have another question moving forward. So, how do you choose the best? Sorry. What can be done if EGFR targeted therapy stops working?
I have to say that depend on the time of progression. This time of the time point of progression disease after TKI treatment. Depend on the situation of progression disease. This is a local progression or systemic progression. For example, patient undergone local progression in the brain without other metastasis progression. We may continue with radiation for the brain match and continue with osimertinib, continue with TKIs, and for patient progression in the systemic, I mean the metastatic lesions, and patient have no clinical practice at all. We also move to the second line option.
Thank you so much for the answer. And our next question is, when should we use combination therapy instead of one treatment alone, for specifically for EGFR mutated non-small cell lung cancer?
Yeah, in Vietnam, as I told you before, we have no approval for the EGFR TKIs combined with other agents. So now I have no experience about combination TKI.
Thank you so much for the answer. So for participants, if you have further questions, feel free to raise your hands and put your questions in the chat box. In the meantime, while waiting for another questions, I want to show the appreciation because I'm myself, I'm a pharmacist, but I did the research and development in this field basically on trying to find new compounds that can potentially be the new treatment for non-small cell lung cancer. Initially, we wanted to do the research about the EGFR mutated one, but it was so complicated and difficult. So I used the wild type, the non-mutant, and from that, we did the virtual screening actually in silico from 268 bioactive compounds derived from marine fungi. We narrowed it down to promising candidates, like 3 promising candidates. And the research is still ongoing because for this, research and development, it will take 15 years if we are lucky, but who knows? But yeah, I would like to show my appreciation. It's fascinating to see how your work complements these findings, and I'd love to hear your thoughts in the future on integrating such new discoveries into clinical practice. All right, let's see whether okay, if there is nothing else to be asked, I would like to say thank you to Dr. Anne for your amazing presentation.
Thank you for having me
Thank you
today.
so much. So for participants, don't forget to fill in the attendance form shared in the chat box. All right, moving forward. Before we begin our fourth session, let me introduce the speaker for this session. Clinical Assistant Prof. Nagavali Somasundaram. Good morning, Dr. Somasundaram. All right. Good morning, Dr. Somasundaram.
Hello, good morning. Just give me a short while. I'll try to share my screen.
Yeah, no worries, Dr. Somasundaram. I would like to introduce your CV first to the participants, and then after that we can start with the session.
Okay, we're not live yet, is it?
Pardon?
Are we live or not yet?
Yes, we are live, but your CV is already on the screen. So I would like to introduce your background first for approximately two minutes. Then after that, we can start with your session.
Okay.
Thank you so much. So let me introduce Dr. Nagavali Somasundaram, a highly regarded oncologist specializing in lymphoma, sarcoma, and skin cancers. Here are some highlights of her exceptional background. Expertise and leadership. Dr. Somasundaram is a senior consultant and the head of the Lymphoma and Sarcoma Division at the National Cancer Center Singapore, showcasing her expertise in these challenging oncology fields. Education and training. She earned her MBBS from the National University of Singapore and holds an MRCP UK and a Master of Medicine in Internal Medicine, reflecting her comprehensive medical training. Research excellence. Her publications focus on advancements in diffuse large B-cell lymphoma, therapeutic strategies for relapse refractory lymphomas, and innovative approaches to cancer treatment. Recognition and impact. Dr. Somasundaram has been honored with multiple awards, including Outstanding Senior Resident in 2015, highlighting her excellence in clinical practice and medical education. Today, Dr. Somasundaram will share her insights on diffuse large B-cell lymphoma treatment updates. Please join me in welcoming Dr. Somasundaram. The floor is yours.
Thank you. Thank you for the kind introduction. And thank you to the organizers for the invitation as well. So I'm very pleased to be here. So as introduced, I'm Naga. I'm a medical oncologist at National Cancer Center Singapore. And today I would like to share some treatment updates on diffuse large B-cell lymphoma. So this will be the overview of what we'll be covering. So diffuse large B-cell lymphoma is a disease that's been rising in incidence both globally as well as among Asian countries, as we see in the graphs over here. So the first graph shows how the global incidence of the disease has been rising, and both in globally and Asia, the non-Hodgkin's lymphomas form part of the top 10 cancers worldwide. Right. Now, when we talk about the biology of this disease, so diffuse large B-cell lymphomas are the most common type of non-Hodgkin's lymphomas, and the cells that are actually destined to develop B cells. So if we look at how B-cell development occurs and how they become diffuse large B-cell lymphoma, B-cell development starts off in the bone marrow, and in the bone marrow, they undergo various processes to actually acquire their B-cell receptors and to mature. And the mature B cells migrate to the secondary lymphoid tissues, as you can see in the picture here, for further development. Over here, depending on which layer of the lymph nodes they develop further in, they develop into the different subtypes of non-Hodgkin's lymphoma. So in DLBCL per se, we actually have DLBCL is actually defined, there are different subtypes. We have the GCB or the germinal center subtype, the ABC or the activated B cell subtype, and there's some that cannot be actually classified. They don't fall under these two categories. We'll look more at that in the next slide. In addition to that, gene expression profiling has also further classified some common genetic mutations that we see in each of these subtypes. So, for example, MYD88 and CD79 mutations are more characteristics of the ABC DLBCL subtype, whereas the EZH2 and the MYC mutations are more common in the germinal center subtype. This doesn't have immediate therapeutic relevance at this point in time, since gene expression profiling is not standard of care in clinical practice, but it does give us more information on the different subtypes of DLBCL and help us understand the disease better. So this is what we were talking about earlier. So using immunohistochemistry Hans criteria, we can classify DLBCL into the germinal center, the activated B cell subtype, and the non-germinal center. So if we look at the pie chart on the right, so generally at the germinal center, and the non-GCB or the activated B cell, and you have a few who cannot be classified into either of these two. And then we have the high-grade B-cell lymphomas, which with MYC and BCL2 translocation, otherwise known as double-hit lymphomas. So this group of lymphomas, they tend to be more, most of them tend to be of the germinal center subtype. The significance of the double-hit lymphomas are that they generally tend to be a disease they tend to have a more aggressive disease course, and there's special nuances in terms of treating the double-hit lymphomas. The double expressor lymphomas mean that there is higher expression of c-MYC and BCL2 without the translocations. So the WHO classification, this is how the large B-cell lymphomas are actually classified. So that's one long list. But in the recent 5th edition of the WHO classification, some of the main changes were actually the recognition of narrowing of the narrowing of the definition of double-hit lymphomas. So previously, MYC, BCL2 translocation or BCL6 translocation were actually considered to be double hit, but that has since been narrowed. The definition has since been narrowed to only MYC and BCL2 rearrangement being called high-grade B-cell lymphoma, which are double hit. And the reason for this is because the DLBCL with MYC and BCL6 rearrangement, they're generally a more heterogeneous group with very varying degrees of clinical outcomes and presentation. So hence, in terms of the therapeutic interventions, they may not be so uniform in this particular group. Whereas the MYC and BCL2 rearranged double-hit lymphomas, they tend to have more of uniformly aggressive disease course. When it comes to staging, we still follow the Ann Arbor staging, whereby stage 1 refers to one lymph node region on one side of the diaphragm. Stage 2 refers to 2 or more lymph node regions on the same side of the diaphragm. Stage 3 disease would be disease above and below the diaphragm, and stage 4 refers to diffuse organ involvement or marrow involvement. In terms of prognostication of the disease, we use the standard IPI scoring. So the IPI scoring consists of these 5 risk factors: age more than 60, Ann Arbor stage 3 or 4, extranodal sites 2 or more, ECOG more than 1, and LDH being raised. Now, IPI score was originally developed in the pre-rituximab era, and based on these risk factors, patients are then grouped to low intermediate, high intermediate, or high risk groups, of which if we look at the 4-year overall survival, the low risk groups, the 4-year overall survival can be as high as 82%. In the high risk group, the overall survival is about 60%. All right, so you can see a significant difference here. The revised IPI is actually a reclassification of the IPI factors in the rituximab era, and the corresponding overall survival is actually as indicated in the table. So coming into management, so in the recent, diffuse large B-cell lymphoma treatment hadn't changed very much in the last 5 to 10 years ago. But in the last 5 years, there has been an avalanche of changes and therapeutics that have been introduced, and we will run through the more important ones in this session today. So starting off with limited stage diffuse large B-cell lymphoma. Limited stage disease is defined by stage 1 or 2 disease according to Ann Arbor staging, and with non-bulky disease. Now, the definition of bulk varies in different studies, but it's generally taken as less than 10 cm. Now, the limited stage diffuse large B-cell lymphomas generally have an excellent prognosis, but on longer-term follow-up, long-term relapses are not that uncommon. So cumulative incidence of relapse at 5 years is about 18 to 23%, but at 10 years, it's 25 to 30%. So these patients do need longer-term surveillance, and hence the treatment also needs to be carefully considered. So in terms of the treatment paradigm for limited stage diffuse large B-cell lymphoma, the standard treatment is R-CHOP times 6. That's the standard traditional treatment as per MIN study. But there are also abbreviated treatment options that are available, and we will look into some of these studies in a short while. So first, I'll touch on the SWOG study. So the SWOG study, the original SWOG study was done in the pre-rituximab era, and essentially the question that they were trying to answer was whether for these early stage disease that can be confined to a single radiotherapy field and non-bulky disease, whether they can get away with a more abbreviated form of treatment. So these patients were then randomized to 8 cycles of CHOP chemotherapy or 3 cycles of CHOP chemotherapy with radiotherapy. And the results, as you can see in the graph, the abbreviated treatment actually demonstrated survival benefit, which was statistically significant. So this then became one of the options of treatment for limited stage DLBCL. Subsequently, in the rituximab era, the question was whether this benefit is still maintained. This was a much smaller single-arm phase 2 study that was done, which actually looked at the role of 3 cycles of R-CHOP plus involved field radiotherapy, and the 4-year OS was actually quite comparable at 92%, though cross-trial comparisons are actually not validated. However, on long-term review of this abbreviated treatment results, so if you can actually look at the graphs on the left and compare it to the graph on the right, the graph on the right is actually R-CHOP chemotherapy versus chemotherapy alone without rituximab. And what is striking, and I've highlighted that in the box about this graph, is actually the plateau. Is actually the plateau that we see, which signifies that patients do have long-term cure with R-CHOP chemotherapy. Whereas if we look at the graphs on the left, and I've highlighted this in the box as well, what we see is that on long-term follow-up, we are missing that plateau, meaning to say that on long-term follow-up, relapses were actually not uncommon. And hence, especially for these patients who are supposed to have very good prognosis, R-CHOP 6 cycles was actually the preferred choice of treatment over an abbreviated 3 cycles plus radiotherapy, given the long-term risk of relapses. So hence, the abbreviated treatment was reserved for situations where patients are unable to tolerate 6 cycles of R-CHOP for various reasons. Okay. Then in 2019, the FLIER study was published. So the FLIER study had a very specific criteria. It looked at patients who are 18 to 60 years old with DLBCL stage 1 or 2, non-bulky disease. And in this study, the non-bulky was defined as 7.5 cm. These patients had to have a normal LDH and a good performance status equal to 1. These patients were then randomized to R-CHOP 3 weekly for 6 cycles, or R-CHOP 3 weekly for 4 cycles with 2 cycles of rituximab. This, the statistical design of this study was that it was a non-inferiority study, and the pre-specified margin that they indicated was via PFS was negative 5.5%. So about 588 patients were recruited in this study, and they were randomized in the 2 groups. And when we look at the primary endpoint of PFS, there was non-inferiority was actually established. So this study then gives us evidence that 4 cycles of R-CHOP is non-inferior to 6 cycles for young patients with limited stage disease and favorable prognosis. However, taking into account the lessons that we learned from the long-term data of SWOG, then practically speaking, my approach would be to consider the FLIER approach only for patients who strictly meet the trial criteria. So if you have somebody who is whose LDH is borderline raised, or who actually has got disease that looks a bit more bulky, that doesn't fit into this definition, then I would prefer to give this patient 6 cycles of R-CHOP. So this FLIER study, still, I think long-term data, we still need to await to see whether we see long-term relapses. But if at all, abbreviated treatment is considered based on this study, one needs to make sure that it actually fits with the trial criteria. Okay. So coming to the next part, which is PET-directed approach. So PET-directed approach is not quite standard of care at this point in time as yet, but there are various studies that are looking at a PET-directed approach in the DLBCL setting. So the first study is the LYSA study, which is a phase 3 study that actually looked at R-CHOP 14 for 4 cycles, and then if they're PET negative, they either get radiotherapy or observation. If they're PET positive, they go on to 6 cycles. Another SWOG study basically looks at 3 cycles of R-CHOP. If they're PET negative, they finish off with 1 more. Whereas if they're PET positive, then they go on to either getting further treatment with RT or chemo. A very similar design for the LISA study as well. So basically the PET-directed approach is actually trying to, is a relatively promising strategy. If you look at the data, it does seem fairly promising. But I think what's not very clear is management of patients with positive interim PET. That's not very clear. And again, as mentioned earlier, long-term data with abbreviated therapies are awaited. Practically speaking, in many countries, including Singapore, interim PET is actually not reimbursed. So patients won't have to pay out of pocket for interim PET. So it is not something that, at least in my own setting, that we use on a routine basis. So we still stick to 6 cycles of R-CHOP. Or if patients meet flyer criteria strictly, then that would be a consideration for limited stage DLBCL. Okay, so now going on to advanced disease. Okay. Right. So rituximab with CHOP, so R-CHOP chemotherapy has been the backbone of DLBCL for the last 20 years or so. Now, in general, 50 to 60% of patients are cured with R-CHOP chemotherapy, and which then means that you will have about 25%, 30% of patients who will relapse, of whom about 10 to 15% will actually have refractory disease. So in order to improve outcomes in DLBCL, the many studies have been done over the last 20 years to try and improve on the R-CHOP backbone. So many drugs were actually added on to the R-CHOP backbone, even drugs that have shown promising activity in the relapse setting, such as lenalidomide, ibrutinib. R-CHOP scheduling has been modified. R-CHOP has been added on to many other drugs, but many of these studies have actually been negative until the polar R-CHOP study that actually came out. So really in 20 years, the first positive study looking at first-line treatment of DLBCL has been the POLARIX study, which we'll look at in a bit more detail. So polatuzumab is actually anti-CD9 monoclonal. It's an anti-CD9 antibody, and essentially it is actually it targets the CD79 cells in the B cells. It internalizes and it injects the cytotoxic agent into the cells, resulting in cell kill. So the POLARIX study actually looked at DLBCL, previously untreated DLBCL patients. These patients were actually randomized to receive either polar R-CHOP or the standard R-CHOP chemotherapy. In the polar R-CHOP, in the arm with the polatuzumab, the vincristine was actually omitted because of overlapping toxicities, right? And these patients were then stratified according to IPI score, disease bulk, and geographic reasons. So in terms of the characteristics of the patients in the study, generally the median age was about 65, 66. Most of the characteristics were well balanced in the polar R-CHOP and the R-CHOP group. So you have the percentage of patients with IPI score of 2 was about equal in both arms, and the number of people with IPI score of 3 to 5 were also relatively equal. A very small percentage of patients in this study comprised of double or triple hit lymphomas. And of note, Asian patients form about 18% of each arm. So this was a positive study So the 2-year PFS was actually improved by 6%, and this was statistically significant with a hazard ratio of 0.73. So first time in 20 years where an improvement in PFS, albeit marginal, was actually shown. All right. Overall survival benefit is not shown as yet, but this is something that we will have to wait for long-term data for. In terms of the polar R-CHOP versus R-CHOP, CNS relapses were not too dissimilar in both the groups, but there was a reduction seen in the need for subsequent therapies in the polar R-CHOP arm. So fewer patients required autologous transplant or CAR T therapy following polar R-CHOP. Now, if we look at subgroup analysis, what is striking here is that the benefit for polar R-CHOP is the greatest in the IPI score of 3 to 5 patient group, and it is also greater in the ABC subtype, although subgroup analysis have to be interpreted with some caution, right? Now, in terms of toxicities, a neuropathy was seen, but the toxicities were generally balanced across both the polar R-CHOP and the R-CHOP arm. So it's predominantly neuropathy and neutropenia that we're actually looking out for, but there weren't any excessive increase of these in the two arms. So the conclusion from the POLARIX study is that the polar R-CHOP showed PFS benefit over R-CHOP in adult patients with IPI score of 2 or higher. There was no difference in overall survival benefit, and subgroup analysis demonstrated that ABC subtype and IPI score of 3 or more patients benefited the most from this treatment. Following the POLARIX study, so earlier we saw that about 18% of patients in each group were Asians. So this Asian population was actually analyzed separately. About 160 patients were of Asian origin. Comparing to the global cohort, the Asian population were generally younger. Their ABC subtype, and fewer of them had bulky disease compared to the global cohort. So the PFS benefit, as shown in the graph, was maintained in the Asian population, and there was a comparable toxicity profile. So moving on to some local data. So a real-world study done in Singapore, looking at about 1,071 patients. This was a retrospective cohort study for patients with DLBCL at our center. And this basically shows that frontline treatment with R-CHOP or R-EPOCH, the 5-year overall survival is in the range of 74%, and the PFS is in the range of about 64%. And in the higher IPI subgroups, the 5-year overall survival is about 70%, and the PFS is actually around 60%. This was actually a study that we published following last year, following a closed group discussion at a national level in Singapore, to look into what our local preferences, treatment preferences for standard and intermediate to high-risk diffuse large B-cell lymphoma. So in Singapore, the preference for standard treatment, standard risk DLBCL is still 6 cycles of R-CHOP. For intermediate or high-risk DLBCL with an IPI score of 2 or above, polar R-CHOP was actually preferred. Now, this was actually last year's data. Since then, in the last 1 year, polatuzumab is actually covered under the cancer drug list in Singapore. So it is actually reimbursed for patients who actually meet the trial criteria. And for double expressor or double hit, generally for double expressors, there's no change. We don't treat them differently from the standard risk DLBCL. We still give 6 cycles of R-CHOP, and polar R-CHOP is a consideration if the IPI score is high. But for the double hit lymphomas, the preference is still for dose-adjusted R-EPOCH, although it hasn't been shown to actually have benefit over standard R-CHOP. So either a dose-adjusted R-EPOCH regimen or a R-CHOP regimen. In the Asia Pacific regions, the main unmet needs in the first line setting would be mainly from reimbursement and drug availability perspective. So even though we have all this evidence that we talked about, many countries in our region do not have access to polatuzumab. So in terms of cost, there's a significant concern as well. So even in my local setting, I think it's only in the last 1 year that we have had access to polatuzumab because of the financial reimbursement. So coming to relapse or refractory disease. Now, the traditional approach to relapse disease, so earlier we saw that 30 to 40% of patients with DLBCL will relapse following R-CHOP, and amongst them about 10 to 15% will have refractory disease. So for many years, salvage chemotherapy and autologous stem cell transplant upon relapse was the main curative approach. And this was based on these few studies. So the first study is actually the PALMER study, which demonstrated that in patients with relapse disease, salvage chemotherapy with autologous transplant had overall survival benefit over conventional treatment alone. And then subsequently, the CORAL study, which actually looked at the options or the choice for salvage regimens. And the CORAL study basically demonstrated that there's no difference in outcomes whether RICE chemotherapy or RDHAP chemotherapy was actually used. And similarly, the LY12 study looked at the GDP versus that. So even though we see the survival benefit in the PALMER study and in the CORAL study with autologous transplant, many retrospective study and including the SCHOLAR-1 study subsequently demonstrated that patients with refractory disease have poor outcomes. So the SCHOLAR-1 study pulled data from both the CORAL as well as the LY12 study, in addition to some retrospective cohorts in their center. And refractory disease was defined by relapse within 12 months from primary treatment, refractoriness to more than 2 lines of treatment, or disease relapse within 1 year of transplant. And in this group of patients, the response rates to any chemotherapy is in the range of 26%, and the median overall survival is about 6.3 months. So this highlights that transplant may not be beneficial in this group of patients, and you need something different to target such resistant disease. So that's where CAR T-cell therapy comes in, and it has truly been a paradigm shift in the management of diffuse large B-cell lymphoma with CAR T in the horizon. So what exactly is CAR T-cell therapy? Basically, this is a treatment where the T cells are actually isolated from the patient's bloodstream, and the T cells are actually modified and engineered, and they actually have a viral vector with a gene, with a CAR-encoded gene that is transducted into the cells. The T cells now express the CAR on their surfaces, and these are then multiplied and reinfused back to the patients, where they then fight the cancer cells. The CAR T binds to the target, and in this case, the target we're looking at is actually CD19. So, and they cause cancer cell kill. So, landmark study that demonstrated, so CAR T-cell therapy initially was established in leukemia, and subsequently this was one of the landmark studies in lymphoma. So this was studied in 2017, ZUMA-1 study where patients with relapsed diffuse large B-cell lymphoma, primary mediastinal B-cell lymphoma, or transformed FL were receiving axi-cell chemotherapy, axi-cell CAR-T therapy. And if we look at the table here, about 64% of DLBCL patients had at least 3 or more lines of therapy, and a significant proportion were actually also fulfilled the definition of refractory disease as well. Now, if we look at this, so earlier we were actually talking about the tail off, or the plateauing of the curve, and that's what is the most amazing about CAR T cell therapy. So it does offer a chance of cure even in patients with very, very refractory disease, and patients go into complete remission. Certainly, it seem to have a higher chance at long-term disease control. So with Zuma-1, there were also other CAR-T products that came into this space, and these studies actually led to the approval of CAR-T cell therapy in the third-line setting, so following the first 2 lines of treatment and the third-line setting. Now, if CAR-T has shown benefit in the third-line setting, then the next natural trend would be to try and see whether it can be brought to the second-line setting. And this is we talked about earlier, where we do actually have an unmet need in the second-line setting, which transplant is not able to offer a solution to, and this would be the group of refractory patients. So these are the 3 second-line CAR-T studies. So the Zuma-7 is looking at the axi-cell product, and Zuma-7 included patients with diffuse large B-cell lymphoma, transformed follicular lymphoma, high-grade B-cell lymphoma, and these patients were actually receiving axi-cell CAR-T cell therapy. So so that's Zuma-7, and then the next study was actually the Belinda study. The Belinda study used the T-cell product, and the Belinda study again used DLBCL in addition to other types of B-cell lymphoma, and generally the patients who were recruited into the study were actually patients who had refractory disease, who fulfilled the trial criteria for refractory disease. And the patients were, and the third sort of study is actually the transform study, which used the lysocell product. So all these 3 studies randomized patients to standard of care chemotherapy and transplant versus CAR-T cell therapy, and the standard of care chemotherapy that can be used were actually mentioned here. Out of these 3 studies, the Zuma-7 didn't allow a crossover if patients progressed on the experimental arm, while the other 2 studies actually did. So when we actually looked at Zuma-7 and the transform study, the axi-cell as well as the lysocell, so both these studies were actually positive studies, and they showed an improvement in event-free survival and overall survival as compared to standard of care, which was chemotherapy and autologous stem cell transplant in a group of patients who had refractory disease. Similarly, the transform study also showed improved event-free survival as well as overall survival compared to the standard of care. The Belinda study, however, using T-cell was actually a negative study. It didn't show any benefit over standard care. So in the second-line space, out of the 3 studies, we have 2 positive studies and 1 negative studies. So why that difference? So the trial designs were different for the 3 different studies. So for example, Zuma-7, it didn't allow any bridging chemotherapy. So bridging chemotherapy means that so when patients actually are diagnosed with relapse disease, They go through a series of, if they're planned for CAR T cell therapy, they go through, a series of evaluations and workup to see whether they are eligible to get CAR T therapy. And in the meantime, following either before or after harvesting, they may need some chemotherapy to keep the disease under control before the reinfusion of CAR T therapy. Now, Zuma-7 didn't allow bridging chemotherapy, so which means that the patients who were recruited in the study were potentially those with a slightly lesser aggressive biology, because these patients could hold on till the reinfusion of CAR T without any additional chemotherapy. The three studies also had varying definitions of event-free survival, meaning to say at which point they assess event-free survival, and that may have had some implications on the results as well. The Belinda study also allowed a second salvage treatment to be delivered to patients with inadequate response, but without being considered an event. So meaning to say that the patients who didn't respond to the first salvage treatment, they could go on to get a second salvage treatment before the failure of which would have been called a progression. But in both the clinical setting and in the other two trials, as long as they progress on the first salvage treatment, that would already be considered an event. And time from randomization to CAR T infusion was longer in the Belinda trial compared to the Zuma-7 study. So for all these various reasons, then these are the various reasons that may potentially account for why the Belinda study didn't meet the pre-specified outcome. Now, in terms of toxicities, so the main toxicities that we see with CAR T cell therapy would be cytokine release syndrome, and the picture on the left demonstrates what are the different organ dysfunctions that can happen with cytokine release syndrome. In addition to that, neurological toxicity or ICANS is commonly seen. So in the acute setting, the common toxicities would be CRS and ICANS. And then subsequently, in terms of other toxicities, we look at allergic sort of reactions. We look at on target of tumor toxicities, as well as insertional oncogenesis, which refers to the black box warning that came out a few months after CAR T cell therapy was actually established, to say that these a group of patients with CAR T cell therapy may have had a higher risk of secondary T cell malignancies. So with these studies, the algorithm for second-line therapy in DLBCL has changed. So for patients who actually have refractory disease, which is defined by relapse within 1 year of treatment, these patients may benefit from, these patients are more likely to benefit from CAR T cell therapy compared to autologous stem cell transplant therapy in the second-line setting. So currently approved products would be Axi-cell or Lyso-cell. And out of the patients who receive the CAR T therapy, maybe about 20% will get cured in the second-line setting. Now, for patients who relapse more than 1 year later, that suggests that the biology may be a bit more favorable, and these patients may still retain some degree of chemosensitivity. Hence, for this group of patients, autologous stem cell chemotherapy and autologous stem cell transplant is still a very reasonable approach to consider. Now, the beauty about CAR T cell therapy is that it has been shown to be tolerable in elderly patients, in patients who are not considered to be eligible for autologous transplant, for autologous transplant. So maybe the older patients, the patients who have a bit more organ toxicities, who may not be eligible for autologous transplant, may still be eligible for CAR T cell therapy. If patients, for whatever reason, do not are not eligible for transplant or CAR T cell therapy, then we have another slew of options that are available. So the next excitement in the DLBCL space is actually in the realms of bispecific antibodies. So these are actually drugs that these are actually drugs that actually have two different antigens or epitopes at the same time. So they target both the CD20 positive lymphoma cells as well as the T cells. So in doing so, they engage the T cells to cause cytotoxic effect to the cancer cells. So that's how the bispecific antibody actually works. To date, there are various bispecific antibodies that are in clinical trials for the different types of lymphomas, and some have been approved. So in the DLBCL space, the glofitamab, as well as the epcoritamab have had FDA approvals for the treatment of DLBCL second line and beyond second line. So a very interesting study that was published recently. This was actually a randomized phase 3 study in transplant ineligible patients following first line of systemic therapy. So for example, for patients with DLBCL who actually progress after first line R-CHOP, but are not transplant eligible. They were then randomized to glofitamab, which is bispecific T-cell antibody, and GMOX combination versus R-GMOX alone. So salvage chemotherapy alone, which is not considered to be curative, versus glofitamab GMOX. The primary endpoint of the study was actually overall survival. And this study basically showed that there was actually overall survival that was demonstrated. And what is very interesting about the glofitamab GMOX study is again the plateau that's actually seen, which suggests that perhaps some of these patients who go into CR may have long-term disease control, although at this point, the timeline for follow-up is still relatively short. So this brings an interesting dimension to the second line space, because now then the question is for patients who actually have disease relapse in the second line setting, would CAR-T be preferred, or would a bispecific antibody chemotherapy combination be preferred? And this question will most likely not be answered by clinical trials unless we have some academic centers that run these trials significantly. This glofitamab GMOX combination had a very low toxicity profile, and it was very well tolerated. So financially and toxicity-wise, sounds very promising. But we'll wait to see where this fits into the space in the overall diffuse large B-cell lymphoma space. Right now, what we have approved in Singapore would be glofitamab and epcoritamab as single agent in the treatment of third line and beyond DLBCL. Epcoritamab is still pending our local approval, but glofitamab has received local approval. Glofitamab is actually given for a 1-year duration, whereas so it's a fixed duration treatment. Epcoritamab, on the other hand, is a continuous duration treatment that is actually delivered until disease progression or toxicity. So other interesting options in this space. So there are many new drugs that are coming in and that are getting approved. So tafasitamab, lenalidomide, lenacapavir, tesiricin, selinexor. So many interesting studies and approvals that are pending, and hence we do expect this relapse refractory space to still continue changing over the next few years as we start to refine the role of the different therapeutics, the CAR T cell, the bispecifics, the newer antibody treatments. So we will, more studies are needed to refine where in the paradigm of the disease, these different treatments come in. All right. And there are many more that are upcoming. So we see some of the different strategies that are upcoming, including things like tri-specific antibodies, tumor microenvironment reprogramming and remodeling, other immune checkpoint kind of inhibition, macrophage-based therapies, NK cell-based therapies, and many drugs and works in the pipeline. Now, coming back to our practical sort of challenges that we face. So we do have many exciting drugs that are available in the market, but the main sort of challenge often tends to be accessibility and cost. So the graph on the left, the Kaplan-Meier curve on the left, is actually a chart from Pakistan study published in JCO Global Oncology. So interestingly, what they did was they actually, in this study, they looked at the outcomes of patients who are treated in private centers versus more public setting, where more resources and better level of care were actually available in the resource enhanced setting. So when they actually compared the outcomes of patients in these two settings, they've demonstrated that patients in resource limited settings do have poorer sort of outcomes. So a year back, even CAR T therapy was actually not reimbursed in Singapore. So cost constraint was actually very, very significant. But again, this year we have gotten approval and some reimbursement for CAR T cell therapy. It is definitely not free. It is more affordable for patients at this point in time with the reimbursements kicking in. Especially if patients do have insurance. For those who don't have insurance, it is still a bit of a strain, but I think we are slowly working towards that. So that's mainly it. Thank you very much for your attention, and I'll be happy to take any questions.
Thank you so much, Dr. Nagavali Somasundaram, for the amazing presentation. So we will now move to the discussion session. Please use the raise hand feature or the chat box to ask your questions. In the meantime, we already have some questions here from Dr. Debbie.
Okay.
Thank you for the lecture, Doctor. One thing we need to monitor during our CHOP treatment is the risk of TLS, tumor lysis syndrome. In your experience, what should we do in this if this condition occurs?
Okay, so thank you for the question. So tumor lysis syndrome is what we see commonly when patients have very bulky disease. And in DLBCL, which is by nature an aggressive disease, and if the tumor bulk is very high, that is when we see potential complications like tumor lysis syndrome. Now, the main management for tumor lysis syndrome is really prophylaxis. All right. So when we actually see a patient for the first time, we need to anticipate that this patient is likely to have potential tumor lysis syndrome, and we institute measures early. So measures such as starting them on hydration, starting them on tumor lysis prophylaxis such as allopurinol, monitoring their input and output strictly. And the treatment, the R-CHOP treatment can be delivered in a fractionated manner. Sometimes when tumor burden is very high, prefacing with steroids for a few days actually does help to bring down the tumor burden before the R-CHOP chemotherapy goes in. Now, despite all these measures, tumor lysis does occur, then early intervention will be important. So these patients will need to have their bloods monitored, the tumor lysis bloods monitored very closely and serially. And if need be, we may need to give drugs like resburicase if the uric acid is very high. Or if the patient is starting to show evidence of renal impairment, high phosphate, then early dialysis would be important as well.
Thank you for the answer. Moving forward, we have some other questions. What are the latest advancement in the first line treatment for DLBCL, and how do they compare to the standard RCHOP regimen?
So as mentioned in the lecture, the biggest advancement is the POLARIX study. So it's the introduction of polatuzumab to the R-CHOP regimen. So polatuzumab to the polatuzumab pola-R-CHP compared to R-CHOP, while it hasn't shown survival benefit, there's a progression-free survival benefit. It's a small benefit, but it is there, and the benefit for pola-R-CHP has been that so the benefit is seen more in patients who have higher IPI scores and ABC subtype, although this is subgroup analysis. And the biggest sort of now with treatments like CAR-T, bispecifics coming into this space in the relapsed refractory setting, one of the main selling points of polatuzumab is that you can potentially reduce the risk of patients receiving subsequent therapies. So I would say that for if polatuzumab is accessible for higher stage, higher risk patients, it can be considered. If it is not accessible, then R-CHOP is still a very, very reasonable standard of care treatment, right? Because at this point, we still don't have survival benefit yet. And in any curative sort of treatment, survival benefit would be key.
Thank you so much. And for the next question, could you please discuss the role of bispecific antibodies such as glofitamab and epcoritamab in the management of relapse or refractory DLBCL?
So at the moment, the bispecific antibodies, the epcoritamab and glofitamab, the approval is in the third line setting and beyond. As I mentioned earlier, the epcoritamab is actually a subcutaneous injection. It is given continuously until disease progression or toxicities. Glofitamab, on the other hand, is a 1-year fixed duration treatment. And the approvals for both would be in the third line setting and beyond at this point in time. There have been meta-analysis done to compare so CAR-T therapy started off in the third line setting. So there have been meta-analysis done to compare CAR-T therapy versus bispecific antibodies to determine which one would be superior in that sense. Because bispecific antibodies are still relatively new and we don't have much long-term data as yet in the meta-analysis, CAR-T therapy still was demonstrated to be superior to bispecific antibodies. So the general algorithm would be that if patients in the third line setting, assuming in the second line setting, for whatever reason, they haven't received CAR-T, then in the third line setting and at point of relapse, CAR-T will be a consideration. If for whatever reason they are not getting CAR-T, then I would consider bispecific. And if they're not suitable for CAR-T or bispecific, then we go down the line of the other options.
Thank you so much for the comprehensive answer. And we have another question here. How is circulating tumor DNA, ctDNA, being utilized in the risk stratification and monitoring of DLBCL patients?
Okay, so at this point, ctDNA doesn't form part of standard diagnostics assessment or treatment, although a lot of studies are actually underway, including some studies that we are doing locally as well, to actually look at MRD and look at ctDNA correlation with minimal residual disease, MRD. But at this point in time, but all these are purely on a research basis. From a standard of care treatment perspective, ctDNA does not have much of a role either in diagnostics or the treatment space at this point in time.
Thank you so much for the answer. Yeah, it's really amazing how the treatments evolve and the treatment options. It reminds me of something um, of a project I worked during my time at University College London for my master's thesis. So I had the opportunity to interview the founder of iPath, which is an innovative platform designed to produce allogenic CAR T cells derived from healthy donors instead of patients. So it's like a smart bedside platform that integrates AI, IoT, automation to manufacture the CAR T cells directly in the hospitals. What's remarkable from this is like a single manufacturing run of the allogenic CAR T cells can yield treatments for more than 100 patients. So it addresses the key challenges in scalability, logistics, and cost, making this advanced therapy more accessible and then also decentralized, which possibly can revolutionize the cancer therapy. But it's still very much in the early stage. It is funded by the EU government. So, yeah, hopefully it's the beginning of something amazing in cancer treatment.
For sure. I mean, thank you for sharing. I think that's really quite amazing. And I mean, the main bugbears with CAR T cell therapy, other than the finances portion, is really the logistics, right? So I think from the time when CAR T cell came into space, I think the time to vein the vein to vein, sort of time, means from the point of apheresis to reinfusing the patient back with CAR T, I think in terms of that time, it has gone down significantly. But yet, I think there's a lot more that can be done. With approvals coming in for CAR T cell therapy in the third line and second line space, where we expect, huge scalability kind of issues, then I think the future of sustaining CAR T may be actually to go down the allogenic route rather than the autologous route. Yeah, so we'll see how the space evolves.
Yes.
Yeah.
Thank you so much, Dr. Nagavali. And for participants, if you have further questions, please feel free to raise your hand or put your questions in the chat box. All right, if there are no other questions, thank you so much for Dr. Nagavali for the amazing presentation, for the answering our questions. And yeah, have a good day. Thank you so much.
Thank you for the invitation as well. Very happy to be part of it. Thank you.
Thank you. So for participants, don't forget to fill in the attendance form in the shared chat box. All right, so now we switch our language to Indonesian to introduce our special speaker, Dr. Prabudi. Izinkan saya untuk memperkenalkan pembicara terakhir dalam sesi hari ini, Dr. Prabudi. seorang ahli bedah onkologi dengan pengalaman luar biasa dalam bedah kanker dan penelitian di bidang tersebut. Berikut adalah beberapa pencapaian dalam karirnya yang mengesankan. Pendidikan yang luar biasa, Dr. Prabudi memperoleh gelar kedokteran dan spesialisasi dalam bedah umum dari Universitas 11 Maret, serta mengembangkan keahliannya dengan subspesialisasi onkologi bedah di Universitas Udayana. Beliau juga meraih gelar magister di bidang ilmu biomedis dan telah menyelesaikan penelitian doktoral dalam ilmu kedokteran. Kepemimpinan dan praktis klinis, saat ini menjabat sebagai konsultan bedah onkologi di Rumah Sakit Brigjen H. Hasan Basri. Dr. Prabudi memiliki pengalaman puluhan tahun dalam onkologi bedah dan perawatan kanker, khususnya dalam pendekatan pengobatan yang canggih dan personal. Kontribusi penelitiannya mencakup karya inovatif tentang peran nuclear factor kappa B NFKB dalam resistensi kemoterapi dan strategi pengobatan baru untuk kanker payudara. Dr. Prabudi juga merupakan fellow dari International College of Surgeons yang menunjukkan pengakuan internasional di bidang bedah onkologi. Hari ini Dr. Prabudi akan membagikan keahliannya dalam topik pembaruan terkini dalam pendekatan bedah untuk pengobatan kanker payudara. Mari kita sambut Dr. Prabudi. Dipersilahkan, Dokter.
Terima kasih Mbak Mega. Sebenarnya saya itu sudah mempersiapkan presentasi dalam bahasa Inggris. Cuman karena Mbak Mega sudah menyampaikan introduction in Indonesian languages, jadi nggak apa-apa, saya akan membahas tentang seksi berkaitan surgical approach of breast cancer treatment in Indonesian language. Ingin saya sampaikan kepada para audiens, kalau misalnya 4 pembicara yang barusan itu berbicara tentang back office dari cancer. Jadi kalau saat ini saya akan menyampaikan front office dari cancer treatment. Share ya. Sudah terlihat belum?
Ya, sudah, Dok, tapi belum di full screen.
Full screen.
F11 mungkin ya biasanya.
Ini ya.
Ya.
Oke.
Perfect.
Untuk para audiens, kalau misalnya dari 4 pembicara sebelumnya itu enggak begitu terlalu mengerti, ya memang agak susah. Jangankan orang yang baru dengar berkaitan dengan masalah cancer ya. Mana? Suara saya terdengar ya, Mbak Mega?
Ya, terdengar jelas, Dok.
Jadi memang agak susah kalau berbicara berkaitan dengan masalah cancer. Kalau misalnya kita berbicara dalam konteks level selular, genomik, proteonomik, itu memang agak susah tuh. Jadi apa yang disampaikan dari pembicara 1 sampai 4 itu orientasi pembicaraannya memang agak rumit. Jadi kita di yang terakhir ini kita akan membicarakan berkaitan dengan cancer, tentang hal-hal yang terlihat aja. Slide-nya. Oke. Secara global statistik, karena saya berbicara dengan kanker payudara, global statistik itu memperlihatkan bahwa ketika kita berbicara tentang breast cancer, maka ini masih sangat relevan karena angka insidence dari breast cancer itu cukup tinggi di Indonesia, walaupun masih lebih tinggi di Eropa dan di Australia, tapi angka mortalitas yang terjadi di Asia, terutama di Indonesia itu masih cukup tinggi, karena ini keterkaitan dengan banyak hal, terutama awareness dari breast cancer itu sendiri. Kita lihat dari peta global, ini untuk angka insidence di Eropa, Kanada, Australia itu lebih gelap warnanya daripada di Indonesia. Sedangkan untuk global color dari mortality, in Indonesia more darker than Australia dan Kanada dan Eropa. Nah, kalau misalnya berbicara dengan bedah untuk kanker payudara, maka kita tidak terlepas dari anatomi kanker payudara. Ini gambaran payudara, bahwa komponen anatomi dari payudara itu adalah glandula atau sekelompok kelenjar payudara, kemudian adanya pembuluh darah vena, kemudian termasuk di dalamnya itu adalah lymph node. Nah, ini penting kita membahas tentang lymph node. Lymph node ini untuk payudara itu kita membagi menjadi 3 level, yaitu level 1, level 2, dan level 3, berkaitan dengan proyeksi lokasi daripada lymph node tersebut terhadap musculus pectoralis minor. Jadi untuk level 1 dan level 2 itu berada di lateral dari musculus pectoralis. Level 2 itu berada di antara musculus pectoralis dan mayor dan minor, dan untuk yang level 3 itu berada di medial dari pectoralis minor. Nah, ini bisa kita lihat, ini adalah musculus pectoralis mayor dan musculus pectoralis minor. Apa yang disebut dengan breast cancer? Breast cancer itu adalah apabila terjadi suatu keganasan di sekelompok kelenjar payudara. Nah, yang ini ya. Jadi kalau misalnya ada keganasan di lemak sini, itu bukan breast cancer yang kita maksud ya. Atau ada keganasan sarkoma, limfoma, dan lain-lain, itu bukan hal yang kita bicarakan pada event hari ini. Klasifikasi breast cancer itu dulu waktu pertama saya masih sekolah konsultan itu masih dibagi 3, yaitu early breast cancer, local advanced breast cancer, dan metastatic breast cancer. Tapi pada beberapa seminar baik nasional dan internasional itu mensimplifikasi klasifikasi dari breast cancer itu menjadi early breast cancer dan advanced breast cancer, di mana metastatik itu dimasukkan ke dalam advanced breast cancer selain local advanced breast cancer. Apa sih yang dilihat dari secara pragmatis klinis untuk mengklasifikasikan breast cancer? Itu gampangannya kalau misalnya kita pakai AJCC atau TNM classification, kan itu tabelnya banyak banget tuh, susah mikirnya. Secara klinis praktis itu kita melihat dari ukurannya aja. Kita melihat ukuran dari primary tumor. Secara primary tumor ukuran itu dibagi 3 sebenarnya. T1 itu kurang dari 2, T2 itu antara 2 dan 5, dan T3 itu di atas 5. Sedangkan T4 itu adalah apabila ada involvement dari kulit ataupun dari dinding dada. Jadi kalau misalnya kita gampang secara early breast cancer itu siapa sih? Kalau early breast cancer itu kalau misalnya T1 dan T2 lah. T2 juga sebenarnya kalau misalnya sudah sampai 4 sampai 5 juga sudah kita geser-geser ke local advance. Ya. Tanpa keterlibatan lymph node atau lymph node itu lymph node aksila itu terdapat 1, maka mungkin itu kita bisa geser ke early breast cancer. Nah, kalau local advance itu kalau misalnya udah di atas 3 secara klinis, biasanya walaupun batasannya itu 5 cm dari T2, biasanya kita pun akan lebih mengarah ke masukin ke dalam local advance. Ya, jadi bagaimana sih mengklasifikasikan breast cancer? Lihat size dari primary tumor, kemudian lihat involvement dari lymph node aksila maupun mamaria interna. Yang ketiga adalah lihat involvement dari adjacent tissue. Maksudnya jaringan-jaringan yang ada di sekitarnya, apakah sudah melibatkan kulit atau melibatkan dinding dada. Kalau melibatkan dinding dada nih, ada payudaranya udah kagak bisa digoyangin, fix. Ya. Nah, selanjutnya sebenarnya apa sih yang dikerjakan oleh seorang surgical oncologist itu? Jadi officially surgical oncologist melakukan kebanyakan pada kanker payudara itu do biopsy, jadi melakukan biopsi untuk menegakkan diagnosa, kemudian melakukan breast surgery, removing primary tumor, dan controlling axillary lymph node atau sering kita sebut dengan axillary dissection. Yuk kita lihat bagaimana evolusi dan apa yang sudah sampai mana kita melakukan hal tersebut untuk tantangan kanker payudara pada saat ini. Nah, dulu evolution of breast cancer biopsy. Dulu tuh traditional biopsy ya. Sebenarnya nggak dulu. Sekarang di Indonesia juga kurang lebih tetap aja melakukan tradisional biopsi karena permasalahannya adalah yang kita lihat ini masih local advance yang kita banyak temui ya. Traditional biopsi itu kita dengan cara excisional biopsi dan incisional biopsi menggunakan pisau bedah atau scalpel. Lebih baru sekarang ini kita melakukan suatu prosedur yang kita sebut dengan minimal invasive biopsi. Minimal invasive biopsi itu termasuk di dalamnya adalah stereotactic biopsi, vacuum assisted breast biopsi, core biopsi, dan fine needle aspiration biopsi. Nah, yang terbaru nih seperti yang sudah Dr. Agus sampaikan adalah itu kita sekarang sedang mengembangkan yaitu yang kita sebut dengan liquid biopsi. Liquid biopsi itu sebenarnya adalah suatu biopsi yang diambil dari cairan tubuh. Tidak hanya dari darah, bisa juga dari cairan peritoneum kalau misalnya dia di rongga perut, ataupun dari cairan pleura kalau misalnya terjadi di paru-paru dengan menggunakan sisa metabolisme seluler, yaitu dengan cell-free DNA, yaitu suatu fragmentasi DNA yang tidak bersama selnya, kemudian ctDNA, circulatory tumor DNA, dan beberapa cancer specific exosome. Nah, kapan kita melakukan excisional biopsi? Excisional biopsi itu diindikasikan untuk tumor-tumor yang kecil. Jadi excisional biopsi secara etimologi itu adalah suatu tindakan biopsi yang kita mengambil secara keseluruhan tumor dengan berbatas jaringan yang sehat. Jadi kalau misalnya tumornya gede, kita ambil semua dengan jaringan yang sehat, maka payudaranya habis. Jadi kita lakukan hanya untuk small tumor. Ya, cut off point sih sebenarnya kita tuh, kalau saya dulu waktu diajarin itu 3 cm aja. Kalau 3 cm lu bisa diambil tuh semua. Tapi kalau misalnya, nah fungsinya adalah untuk diagnosis dan treatment. Kalau misalnya ternyata yang sudah kita ambil itu jinak, maka sudah selesai. Dan apabila kalau misalnya diperuntukkan untuk diagnosis, makanya kita harus menambahkan penanaman dari titanium clip. Kalau misalnya kalau misalnya ternyata itu ganas, kita harus tahu lokasi pengambilan tumornya. Kalau enggak, kita akan kehilangan jejak. Makanya excisional biopsi dilakukan pada low risk lesion. Excisional biopsi perform for low risk lesion. Karena kalau misalnya kita curiga ini bahwa tumor ini ganas, kalau kita ambil semua, yaitu kita takut kehilangan jejak untuk melakukan neoadjuvant chemoterapi. Nah, untuk incisional biopsi ya hanya untuk tumor-tumor yang besar yang kita curigai invasif. Kemudian apabila diagnosisnya itu lebih tend to malignancy, dia lebih ke arah malignancy. Kemudian hanya digunakan untuk pre-treatment assessment untuk menentukan grade tumor, subtype, IHK, dan lain sebagainya untuk pelayanan systemic therapy. Selanjutnya adalah minimal invasif biopsi yang sudah disampaikan tadi. Stereotactic biopsi itu dilakukan di radiologi department ya dengan serial exposure of mammografi menggunakan vacuum assisted biopsi, tapi kita melihat secara serial dari gambaran mamogram sesuai dengan lesi kalsifikasi pada payudara yang kita curigai. Berbeda dengan VABB kurang lebih hampir sama, vacuum assisted breast biopsy, tetapi ini real time dengan menggunakan ultrasound transducer. Core biopsi itu adalah suatu pengambilan jaringan juga sama seperti biopsi, hampir sama, cuman berbeda dengan fine needle aspiration biopsi. Core biopsi itu menggunakan a little bit large bore of needle ya. Jadi fine needle itu lebih kecil, di antara sekitar kurang lebih 23 gauge. Untuk core biopsi bisa sampai 14. Untuk fine needle aspiration biopsi, beberapa secara klinis ini agak sulit kita bisa terima, maksudnya untuk memberikan treatment, planning of treatment, karena yang kita dapat ini kurang lebih hanya sel-sel tanpa mendapat microenvironment. Untuk saat ini fine needle aspiration biopsi atau sering kita sebut sitologi ini bukan menjadi gold standard untuk penegakan diagnosa. Jadi yang sering kita kerjakan itu adalah core biopsi dan VABB. Stereotaktik pun kayaknya agak, kalau yang saya pengalaman klinis saya jarang dilakukan karena exposure terhadap jaringannya itu terlalu masif. Yang terakhir yang lagi baru-baru ini dikembangkan adalah liquid biopsi. Liquid biopsi itu digunakan untuk screening. Ini adalah contoh liquid biopsi pada pasien laki-laki umur 37 tahun ya, yang baru saja kehilangan saudaranya yang meninggal disebabkan karena suatu keadaan cancer tapi still unknown. Jadi apa sih sebenarnya cancernya? Maka dia melakukan suatu screening, sebenarnya gue sakit apa sih, ada cancer apa sih? Maka hasilnya seperti ini nih saya sampaikan. Ini adalah bentuk kalau misalnya pasien screening ya. Ini hasilnya adalah setelah dilakukan prosedur isolasi, konsentrasi dari sel yang dicurigai itu adalah 3,2 sel ya, dimana ya dengan kalau misalnya breast cancer itu kurang dari 5, kurang dari 20, jadi ada satu cut off point. Nah, ini tidak bisa dijadikan sebagai suatu diagnosis, penegakan diagnosis secara inisial, tapi ini melihat adanya suatu kondisi faktor risiko ketika kita melakukan liquid biopsi pada pasien-pasien dengan screening, maka yang kita dapatkan bukan diagnosis tapi faktor risiko. Fungsi lain dari liquid biopsi itu adalah as a guidance for adjuvant systemic therapy. Lancet di tahun 2005 itu menyampaikan ilustrasi bahwa pasien cancer no additional therapy gambarannya seperti diagram batang yang di atas nih, ya. Kemudian kalaupun kita bisa memberikan kemoterapi hanya memberikan 12,6%. Ya 63,1 mau dikasih kemoterapi nggak mau dikasih terapi ya segitu. Ya. Jadi kalau misalnya dengan kemoterapi kalau misalnya kita memberikan secara presisi, ya kita secara presisi, maka kita akan memberikan kurang lebih sekitar 12,6% benefit. Jadi mengurangi angka kematian yang warna merah ini dengan warna kuning, mengurangi angka kematian itu kurang lebih sekitar 12,6%. Nah, seperti yang dilihat di ilustrasi sebelahnya pada jurnal yang dikeluarkan Lancet di tahun 2005, setelah dilakukan operasi, kita cek ctDNA-nya. Kalau negatif, no further therapy. Kalau setelah kita lakukan surgery, kita lakukan ctDNA, dilakukan liquid biopsy, kemudian kita melihat ctDNA-nya positif, mungkin masih memberikan benefit kurang lebih sekitar 12,6% dengan kita melakukan suatu serial observasi pada ctDNA melalui liquid biopsy. Okay. Nah, untuk yang kedua adalah breast cancer surgery. Jadi breast cancer surgery itu ada satu paradigma bahwa sebenarnya itu operasi kanker payudara itu udah lama, tapi baru Halsted nih yang menyampaikan atau reporting secara ilmiah. Jadi kita baru bisa melacak manuskrip dari Halsted aja berkaitan dengan kanker payudara, dan sampai sekarang kita sudah sampai ke era atau fase onkoplasti breast conserving. Nah, di tahun 1907 Halsted, ini Bang Kumis, melaporkan dari John Hopkins Hospital bahwa kanker payudara itu adalah suatu kondisi di mana harus dilakukan suatu tindakan yang sifatnya radikal. Mengangkat semua jaringan payudara disertai dengan otot-otot pectoralis mayor dan minor beserta lymph node yang berada di sekelilingnya sampai dengan level 3. Level 3 itu maksudnya adalah lateral side dari pectoralis minor, above and below side dari pectoralis minor, dan medial side from pectoralis minor. Dan ini walaupun sudah dari 1907 masih kita lakukan di Indonesia untuk pasien-pasien kanker payudara yang menginfiltrasi muskulus pectoralis mayor dan minor. Atau kita melakukan salvage surgery setelah terjadi kekambuhan yang menginfiltrasi pectoralis mayor dan minor. Kemudian di tahun 1940 dan atau 1950, John Maiden itu mempopulerkan suatu teknik dari Auchincloss dan Pate berkaitan dengan adanya satu reduksi dari operasi kanker payudara sebelumnya. Jadi tetap mengangkat semua jaringan payudara, tetapi ini yang diambil hanya level 1 dan level 2. Level 3 tuh kalau misalnya memang secara pada saat durasi operasi kita temui adanya suatu pembesaran di level 3, maka kita ambil. Dengan, ya ini musculus pectoralis minor, dengan mengangkat atau retracting dari musculus pectoralis minor. Dan ini adalah masih gold standar dari mastektomi yang dilakukan di Indonesia. Dan untuk radiasi hanya pada selected patient, dan dilakukan juga setelah dilakukan neoadjuvan kemoterapi. Nah, ini adalah contoh This is the figure of how we perform modified radical mastectomy. Kita melakukan steward oval pattern pada payudara, kemudian removing all breast tissue, and we dissect all the level 1 and level 2 axillary node, and we left behind the pectoralis minor after we clean the level 2 lymph node basin. Terus gimana ininya, tingkat keamanannya, kemudian overall survival, disease-free survival. Ternyata Alabama Breast Cancer Project itu menyampaikan kurang lebih hampir sama nih, ya, dengan total pasien itu 136 dan 175. Kaplan-Meier di sini menunjukkan pada Project Alabama Breast Cancer menunjukkan survivalnya kurang lebih hampir sama. Nah, ini gambaran pasien dari yang dilakukan untuk yang sebelah kanan. Ini masih bagus ininya, gambaran dadanya itu dia masih tertutupi tulang iganya dengan muskulus. Nah, yang sebelah kiri ini langsung kontak antara kulit dengan kosta. Ini berarti ini halted prosedur. Profesor Umberto Veronesi di tahun sekitar 1970-1971. Nah, dengan bergesernya dan meningkatnya awareness of breast cancer di Eropa, maka yang di pasien-pasien yang di sana pun akhirnya yang datang tuh nggak dalam kondisi yang parah-parah. Maka yang datang ke tempat kawan-kawan ini, ke Prof. Umberto ini kecil-kecil. Makanya dia melakukan suatu penelitian dengan membandingkan bagaimana nih kalau misalnya pasien kita lakukan breast conserving therapy, kemudian dibandingkan dengan sama yang pasien kita lakukan MRM dan radikal tadi. Termasuk di dalamnya itu ada Dr. Bernard Fisher dan Stewart Anderson. Maka hasilnya adalah ini, ya. Setelah dilakukan mastektomi, lumpektomi, dan lumpektomi dengan radiasi, setelah dilakukan perbandingan, ya, maka dari disease-free survival, jadi angka pertama dia penegakan diagnosa, kemudian dia terjadi rekurensi, itu hampir sama antara mastektomi, lumpektomi, ataupun lumpektomi dengan radiasi. Termasuk distant disease-free survival-nya, maksudnya mulai dari penegakan diagnosa sampai dia timbul distant metastasis. Kurang lebih hampir sama tuh, mau dikerjain lumpektomi, mau dikerjain lumpektomi dengan radiasi, mau lu kerjain dengan mastektomi, sama aja. Ya, begitu juga dengan overall survival. Mau diambil semua, mau diambil sebagian, atau mau diambil sebagian kemudian dilakukan radiasi, sama aja. Nah, ini didukung juga dengan studi Milan, dia membandingkan Halsted dengan quadrantektomi and radioterapi. Ya, kita menunjukkan bahwa Kaplan-Meier grafik ini menunjukkan dua garis yang hampir berhimpit. Jadi ini maksudnya dia sama aja, lu radikal mastektomi sama lu quadrantektomi, tapi lu radioterapi sama aja. Nah, ini kita bisa melihat dari sistemik literatur review dengan menggunakan lebih dari 500, ada juga yang lebih dari 1000, ada yang 2000 populasi, ya, di mana populasi karakteristiknya ini lebih banyak. Untuk studi 1 sih kayaknya kok nggak melihat T, ya. Kalau misalnya T agak harus, saya lebih ke NHBB06 ini kan melakukan suatu karakteristik populasinya itu dari lihat size, ya. kurang dari 4 cm, kurang dari 2 cm, dan localized DCIS dengan comparison dari systemic literature review ini adalah bagaimana radikal mastektomi dibandingkan dengan lumpektomi, simple mastektomi. Dengan primary outcome-nya, kita nilai dari perbandingan itu apakah DFS-nya, DFS itu disease free survival-nya, distant disease free survival-nya, sama overall survival-nya sama apa enggak. Jadi primary outcome-nya kita bandingkan nih dari 1079 dan berapa banyak ini kita bandingkan antara mastektomi dengan simple mastektomi yang kita lihat dari apakah itu lumpektomi dengan iradiasi, kemudian kita lihat primary outcome-nya ternyata sama. There is no significant difference, no significant difference. Dari empat literatur yang direview, hampir semuanya tidak ada suatu perbedaan berkaitan dengan disease free survival dan overall survival dibandingkan antara yang modified radical mastectomy atau radical mastectomy dibandingkan dengan lumpektomi. Hal ini menunjukkan suatu benefit ya, terjadi reduksi. Tadinya radikal banget, sekarang kita bisa dengan lumpektomi. Nah, akhirnya kita sampai kepada perhitungan meta-analisis. Ini adalah forest plot, ya, forest plot membandingkan antara oncoplastic surgery dan breast cancer free surgery. Beberapa dari penelitian ini menunjukkan bahwa favor itu ke oncoplastic surgery. Apa sih oncoplastic surgery? Oncoplastic surgery adalah suatu tindakan surgery pada kanker payudara yang tetap yang masih memikirkan dari fungsi dari estetik pasien. Ya, kita dengan teknik-teknik yang memperhatikan dari ruang bangun 3 dimensi dari payudara tersebut. Nah, ini adalah contoh-contoh teknis yang kita gunakan. Yang ketiga dan yang terakhir itu adalah manajemen axillary node. Jadi dulu, sekarang juga sih masih. Dulu itu kita melakukan axillary lymph node dissection. Jadi semua tuh seperti yang saya bilang nih, ya, di bawah vena axillary dan di lateral di bawah di antara musculus pectoralis minor sampai ke samping nih kita habisin semua. Level 3 itu di medial pectoralis minor, kalau ada kita ambil, kalau nggak usah. Bisa pakai pate dengan mengambil pectoralis minor atau ouching close, hanya melakukan retraksi pada pectoralis minor. Kita ambil semua. Dan yang sekarang, nah, kita mencoba untuk melakukan reduksi dari kondisi yang kita kerjakan sebelumnya dengan melakukan sentinel lymph node biopsi. Apa sih sentinel lymph node biopsi itu? Jadi sentinel itu adalah first station lymph node from primary tumor. Jadi kita lakukan dye injection atau satu radioisotop yang mungkin nanti akan kita bisa trace. Kalau kita ketahui ada spreading dari sentinel lymph node dengan menggunakan radio probe, kemudian kita berikan ke PA, ternyata ada penyebaran di situ, ada satu treatment tersendiri yang kita lakukan untuk axillary lymph node-nya. Nah, ini adalah systemic literature review juga untuk yang membandingkan antara interventionnya, ya. Kalau kita membaca systematic literature review, kita melihat populationnya itu kurang lebih sekitar segini. Kemudian interventionnya adalah ALND dan SLNB. Kemudian comparisonnya itu ya ini sama juga ALND dan SLNB. Kemudian kita lihat outcome-nya. Jadi ketika kita mau baca systematic literature review, baca PICO. PICO lihat population-nya banyak apa enggak, kemudian ada homogenisasi karakter populasi apa enggak, kemudian intervention-nya apa, setelah kita lihat intervensinya apa yang dibandingkan, comparison, kemudian apa sih yang dinilai outcome-nya. Nah, ini outcome yang dilakukan, yang dicari adalah arm and shoulder morbidity. Kita tahu bahwa apabila axillary lymph node biopsi, axillary lymph node diseksi, maka akan terjadi peningkatan resiko lymphedema. Ya, ini arm and shoulder morbidity-nya dinilai nih antara ALND dan SLND. Kemudian QOL, quality of life-nya gimana? Ya. Kemudian ada lagi untuk yang studi yang kedua itu termasuk di dalamnya overall survival dan disease-free survival. Terus hasilnya gimana? Ternyata ALND dan SLNB itu sama aja. Malah dia bilang begini, SLNB was associated with reduced arm morbidity and better QOL. Jadi sebenarnya SLNB lebih bagus kalau misalnya kita terapi pada pasien kita. Di mana overall survival sama disease-free survival-nya pun sama. Dan tidak ada perbedaan axillary recurrence. Dengan kita lihat 5.611 pasiennya. Tapi yang harus kita tekankan, ya, yang harus kita lihat populasi karakteristiknya. Populasi karakteristiknya kurang dari 4 cm. Ya, yang diperiksa. Terus nanti kalau misalnya kita kerjain invasive breast cancer-nya 10 cm, kemudian lu kerjain SLNB, ya sama aja, kagak bisa. Nggak support nih studi ini nih, karena dia cuma kurang 4 cm. Nah, hal-hal ini hanya bisa dikerjakan sebenarnya pada pasien-pasien yang sifatnya early. Ya, lihat aja. Kurang dari 4 cm, T1, T2, kurang dari 5 cm, T1, T2. Ini yang agak kurang, saya sih kayaknya agak kurang ini nih. Pada studi ini, any tumor size kok kayaknya agak. Tapi dia bilang clinical not negatif, secara klinis tidak kita temui. Ya oke lah. Tapi kalau misalnya any tumor size, kalau misalnya ukuran primary tumornya 10 cm, agak ngeri juga sih ya. Nah, mungkin kita harus baca lagi nih yang studi almanaknya langsung pada resources-nya. Oke? Nah, terus gimana sih yang benar ngerjain axillary disseksi ya? Terus bagaimana implikasinya SLND itu? Nah, ini dia nih. Jadi, kalau misalnya sekarang nih seorang surgical oncologist ya, itu lihat dulu nih secara klinis N-nya zero apa enggak? Dicek tuh. Enggak ada. Oke. Kita lakukan SLNB. Kalau pada SLNB sentinel lymph node biopsi, setelah sentinel lymph node kita lihat secara patologis. Nah, ini kan C clinical N0, P N0, berarti nggak usah dibersihin tuh lymph node yang di aksila, ya. Atau ketika dilakukan SLNB ada spreading pada first stationary lymph node ya, from primary tumor, tapi cuman 0,2 atau sampai dengan 2 mm aja nih spreadingnya. Setelah itu dia nggak ada. Itu yang disebut dengan N1 micrometastasis. Ya, N1 ini ya udah kita lakukan BCS atau mastektomi, nggak perlu di ALND. Nah, terus bagaimana nih kalau N-nya positif, ya kita lihat juga berapa banyak yang terlibat. Kalau cuman dua doang yang positif, ya boleh lah. Ini masih agak abu-abu nih. Bisa dilakukan BCS. Bisa dilakukan tidak perlu dilakukan, atau kalau misalnya lebih itu adalah mandatory. Ya, lebih dari 3 SLN positif mandatory untuk dilakukan axillary lymph node biopsi. Axillary lymph node disseksi. Nah, kalau misalnya clinical note positif, nggak usah mikir-mikir tentang ini, digas saja langsung axillary lymph node diseksi. Ya, nah itu hampir hal yang sama pada pemberian neoadjuvan kemoterapi ataupun radiasi terapi. Akosok Z1011 ya. Kita lihat lagi. Jadi kalau misalnya kita lihat Kaplan-Meier, kalau misalnya kita punya obat baru gitu ya, atau tindakan baru, kita bandingkan dengan yang sudah established. Kemudian kita lihat aja nih Kaplan-Meiernya. Yang dilihat selalu overall survival sama disease-free survival. Ternyata SLNB, ini maksudnya SLNB, simple lymph node disseksi, atau bisa juga orang-orang ngomongnya selective lymph node disseksi, ya. Itu dari Kaplan-Meier ini hampir sama. Jadi kalau dari Kaplan-Meier ini menunjukkan kurang lebih hampir samalah antara SLNB dan ALND. Tapi kita lihat karakteristik dari populasinya seperti apa. Ya. Selalu T1 dan T2. Ya. Ya, kalau misalnya T3 T4 agak ngeri-ngeri sedap kalau kita tidak intervensi pada axillary lymph node-nya. Nah, bagaimana untuk yang pasien 1-2 positif, Akosok Z011 juga menunjukkan tidak ada perbedaan antara disease-free survival dan atau overall survival antara ALND dan pasien di mana lymph node sentinelnya 1-2 yang positif. Oke, kita masuk pada conclusion. Dulu Harstead selalu bilang, more extensive local excision, greater chance to survive. Tapi tidak juga. Di zaman-zaman pertengahan tahun 2000, less is more, bigger is not better. Jadi masih kita melakukan suatu reduksi dari prosedur yang kita lakukan pada breast cancer. Tapi sekarang yang kita pikirkan adalah recent pola pikir para surgical oncologist adalah bagaimana kita mendapatkan effective treatment dengan achieve excellent cosmetic result. Nah, apa yang take home message? Jadi take home message itu surgery depend on apa yang kita hadapi sekarang. Ya, makin kemari makin kecil tumor-tumor kanker yang kita hadapi. Tapi bukan kita sih, itu di Eropa. Kalau di Indonesia, di Asia, di tempat saya kerja kok masih gede-gede ya. Jadi kalau misalnya kita berbicara, if we talk about globally, ada penurunan diameter dari pasien-pasien yang kita hadapi. Ini disebabkan oleh adanya global awareness about breast cancer. Kemudian teman-teman di pembicara 1, 2, 3, dan 4 itu yang kerja siang malam, pagi, sore, kayaknya nggak holiday juga. Ini mikirin tentang improvement of systemic therapy. Ini makanya bahasan-bahasannya itu agak bingung. Kalau saya sih tinggal lihat tumornya kayak gimana, tinggal nggak begitu susah lah. Kita tuh orang-orang pragmatis dan simpel. Nah, oleh karena itu recent concept of breast cancer surgery adalah deeskalasi seperti yang saya sampaikan. But it can be done only in one condition. Yeah. We have to make a good patient selection because the best result is about how to surgeon make a good patient selection. Nah, kalau misalnya pasiennya seperti ini, ya, pasien seperti ini, maka tidak ada lagi yang bisa kita lakukan according to recent update surgical approach. Like Michael M. Sosramdi told us, in surgical oncology, patient selection is paramount. It's the number one factor that determines the success of treatment. So for the last thing, I want to give you a pantun. Pantun is a traditional uh, habit for Kalimantan lecturing. I want to give you a pantun. A monkey is stealing apple pie. It presses a button to open gateway. I promise this is not a goodbye. I will see you again someday. Thank you, Mega. Assalamualaikum warahmatullahi wabarakatuh.
Masuk dok, masuk pantunnya. Terima kasih Dokter Prabudi atas presentasinya yang sangat insightful. Sekarang kita akan melanjutkan ke sesi diskusi. Silakan gunakan fitur raise hand atau kotak obrolan untuk mengajukan pertanyaan Anda. Kotak obrolan, chat box ya. Baik, jadi sambil menunggu pertanyaan-pertanyaan selanjutnya, udah ada beberapa pertanyaan yang masuk nih, Dok. Yang pertama, bagaimana cara menentukan pilihan antara operasi konservasi payudara dan masektomi pada pasien kanker payudara stadium awal?
Itu udah ya. Bisa saya
Ya, itu
jawab?
yang pertanyaan pertama. Bisa, boleh dok.
Stadium awal, stadium 1 sampai stadium 2 lah ya. T1 atau T2. Kita lihat. Jadi payudara itu dibagi atas 5 kuadran. Ya. Kita lihat nih. Yang pertama, apakah tumornya itu besar apa enggak? Ya. Ini untuk menentukan apakah mastektomi atau breast cancer conserving surgery kan? Ya kan? Kita lihat. Ini kita bagi 5 dulu tuh. Payudara ada kuadran lateral atas, kuadran lateral bawah, medial, pokoknya kita ada 5 deh tuh. Apakah dia itu menempati 1 atau 2 kuadran? Jadi saking gedenya dia itu tumor size-nya itu melewati 2 kuadran atau tidak. Kalau lewat dari 2 kuadran ya mendingan di mastektomi. Ya. Kemudian dia dekatnya dekat di sentral kuadrannya. Nah kan sentral kuadran itu ada kita bagi 5, kemudian di tengahnya. Kalau dekat sentral kuadran, mendingan mastektomi. Kemudian kita lihat grade-nya dari laporan patologi gimana. Grade patologi itu menyampaikan terjadi bahwa sel kansernya itu grade 3. Dia bilang itu grade 3 misalnya. Oh ini high risk. Kalau high risk, mendingan mastektomi. Ya. Kemudian oke, dia kecil, ya. Oke, dia kecil, tapi setelah hasil laporan dari mamografi dia itu multisentris, kecil di satu kuadran, tapi kuadran lain juga ada kecil juga. Kuadran lain ada juga, itu yang kita sebut dengan multisentris, ya. Kecil-kecil satu. Ya kalau begitu mendingan dilakukan mastektomi. Kecil tapi multisentris atau multifokal, ya mendingan kita lakukan mastektomi. Jadi it's really strict patient selection to perform de-escalation. It's almost a very little number of them in Indonesia. Kemudian yaitu jadi involvement adjacent tissue, yaitu kena ke ini enggak, kena ke apa, kulit atau enggak, nempel ke dinding dada apa enggak, kan? Itu juga harus menjadi our consideration. Setelah itu it is mandatory for every patient with breast cancer surgery followed by radiotherapy. It is mandatory, ya, as adjacent treatment. Jadi kalau misalnya mau dilakukan di escalation di tempat dia, dan dikasih tahu juga ke pasiennya bahwa setelah ini harus dilakukan radioterapi. Kalau tidak, ya angka kejadian rekarensinya menjadi lebih tinggi. Jadi seperti itu. Ya, banyak hal yang harus menjadi consideration if we convert mastectomy to lumpectomy or breast cancer surgery. Mudah-mudahan bisa menjawab.
Terima kasih dok atas jawabannya. Ada pertanyaan masuk lagi nih dok dari Dr. Abdullah Putra. Selamat siang, izin bertanya untuk prosedur BCT sebaiknya jarak waktu antara operasi dengan radioterapi seberapa lama ya dok? Terima kasih.
Jadi sebenarnya sih lebih cepat lebih bagus karena sifat dari radioterapi itu hampir sama dengan surgery ya, di mana fungsinya adalah local control ya. Tapi sebaiknya untuk pasien yang baru saja dilakukan operasi itu dipastikan luka operasi, range of movement dan lain sebagainya itu sudah kembali normal. Batasnya sih lebih ideal ya. Ideal itu kita kalau misalnya kita melihat aspek compression grafik, maka sebenarnya akan menjadi lebih baik kalau misalnya diberikan kurang dari 6 minggu. Apa yang disebut dengan compression grafik? Compression grafik itu adalah grafik di mana terjadi suatu peningkatan proliferasi sel kanker secara eksponensial. Berdasarkan itu, kita biasanya lebih ideal kurang dari 6 minggu dan kita set. Kesulitannya di Indonesia, ya Dokter Putra, ya kesulitannya di Indonesia itu angka availability dari radioterapi installation itu jauh di bawah standar IAEA. Standar IAEA itu menunjukkan bahwa seharusnya satu radioterapi itu mencakup 1 juta populasi. Jadi setiap 1 juta populasi di satu daerah itu harus punya satu instalasi radioterapi. Ya kalau misalnya kita melihat Kalimantan itu populasinya sekitar 4,4 juta, tapi yang baru ada radioterapinya baru 1. Jadi itu sangat ironis sekali ya. Demikian Mbak Mega, kecuali kalau di Budapest banyak ya Mbak Mega radioterapi. Saya pindah Budapest ya.
Kan udah pernah visit dok.
Oh iya, siap. Sana lagi siap.
Oke, kemudian ada pertanyaan lanjutan nih dok. Sebentar. Ya, apa saja perkembangan terbaru dalam teknik bedah onkoplastik dan bagaimana teknik ini meningkatkan hasil bagi pasien?
Gimana? Apa saja?
Apa saja perkembangan terbaru dalam teknik bedah onkoplastik dan bagaimana teknik tersebut meningkatkan hasil bagi pasien?
Ya sebenarnya banyak sih. Maksudnya kalau misalnya mau berbicara detail di sini sih banyak ya. Cuman saya akan menjawab secara ini aja, grand picture ya. Kalau misalnya kita melihat sebenarnya di dalam operasi itu ada yang kita sebut dengan safe operation, ya. Yang kedua itu adalah excellent operation. Excellent operation itu adalah yang seperti yang disampaikan adanya onkoplasti, onkoplasti surgery. Onkoplasti surgery itu kan ada onkoplasti surgery itu ada yang 1, ada yang 2, OPS itu ya. OPS 1 apabila yang diangkat itu kurang dari 20% bentuk limas payudara. Nah, itu tergantung tuh, kan ada payudara kap D, kap C, kap B, kap A juga kan gitu kan. Bagaimana kita bisa mempertahankan bentuk limas dari payudara itu? Nah, kalau dari kurang dari 20%, ya itu biasanya kita bisa melakukan OPS1, yaitu dengan melakukan displacement. Kita menutup kehilangan 20% payudara itu dengan jaringan itu sendiri. Ya, atau bisa juga itu dengan melakukan apabila dalam volume tertentu kita harus menggunakan suatu flap. Flap itu adalah memindahkan jaringan dari tempat lain untuk mengisi volume yang hilang di payudara. Itu bisa dari otot, bisa dari lemak dan lain sebagainya. Ya, untuk mempertahankan. Jadi dioperasi nih kanker payudara nih, maksudnya payudara yang dioperasi biasanya kan diambil langsung hilang kan bangunan 3 dimensi payudara. Tapi kalau ini bagaimana kita ambil itunya tapi kita isi dengan yang lain. Atau kita juga bisa lakukan misalnya dengan teknik nipple sparing mastektomi. Kita ambil cuman jaringan payudaranya aja. Dengan prinsip-prinsip yang sudah kita bicarakan yang tadi ya. Dengan prinsip-prinsip kita mengambil seluruh jaringan payudara beserta fascia menurut Auchin Close kita tadi MRM itu ya. Dan kita meninggalkan kulit dan nipple sparing mastektomi. Itu bisa saja, tapi dengan syarat-syarat tertentu juga. Syarat-syarat tertentu, ya kalau misalnya kita mau nipple sparing, pastikan dong nipple-nya nggak infiltrate by tumor, ya kan? Atau skin sparing mastektomi. Secara suputan kita ambil tuh jaringan payudaranya. Tapi skin sama nipple-nya kita pertahankan. Tapi kita pastikan juga bahwa tumor itu nggak infiltrate ke skin. Jadi pada prinsipnya sebenarnya kalau misalnya kita mau melakukan breast cancer surgery, ya kita pastikan bahwa yang kita ambil, ya yang bukan yang kita ambil, yang kita tinggalkan itu benar-benar sudah bebas dari sel kanker payudara. Jangan akhirnya begini, as a surgical oncology, lu harus tetap sebagai surgical oncology, kita bukan plastic surgery soalnya ya. Kalau misalnya kita berbicara berkaitan dengan surgical oncologist, the most important thing is what we concern is how to remove cell cancers from the body. Jadi itu concernnya, ya. Jadi as long as we can make sure that there is no cell cancer left in the tissue, that's okay. Dan hal tersebut kalau misalnya kita bisa menggunakan teknik-teknik onkoplasti untuk breast conserving surgery secara psikologis, ya tidak hanya dia menjadi lebih percaya diri, tapi secara psikis dia juga menjadi lebih dapat menerima ya kondisi tersebut. Seperti itu Mbak Mega, mudah-mudahan bisa menjawab.
Wah, terima kasih sekali dok atas jawaban dari pertanyaannya. Kemudian ada lagi nih dok, pertanyaan dari Dokter Aprianti. Izin dok, saya 2 kali menemukan di klinik primer massa solid di payudara, tapi tampak jinak sekitar 1 cm. Saya rujuk spesialis bedah setelah edukasi, tetapi ternyata keganasan hasil PA-nya. Apakah massa di payudara apapun disarankan biopsi saja tanpa melihat klinis keganasan? Terima kasih.
Dokter Aprianti ya. Jadi untuk Dokter Aprianti kita kembali kepada bagaimana how to make a diagnosis in tumor case ya. Jadi kita kembali kepada trias diagnostik. Kita kembali kepada trias diagnostik, bagaimana kita menegakkan suatu diagnosa tumor. Apa sih trias diagnostik itu? Trias diagnostik itu adalah, pertama adalah physical examination. Jadi periksa secara klinis. Oke, gambarannya itu adalah, kan? Gambarannya itu adalah jinak nih kayaknya. Apa sih jinak? Jinak itu kalau misalnya kita raba tuh dia mobile, ya kan? Dia di payudara nih, kita raba dia mobile. Kemudian ya single lah ya. Terus besarnya ya variatif sih. Tapi yang kita lihat adalah permukaannya tuh rata. Jadi bulatnya halus gitu loh. Misalnya, jadi kita rata nih, nggak ada lekak-lekuk di tepinya. Jadi tepinya rata, ya halus, dan batasnya tegas. Nah, itu biasanya mengarah ke jinak. Biasanya loh ya, biasanya loh. Ya. Kemudian kita lakukan USG. Yang kedua adalah imaging. Tadi adalah physical examination. Yang kedua itu adalah imaging. Dari trias tuh, satu physical examination, yang kedua imaging. Imaging bisa dilakukan USG. USG kita lihat batasnya tegas apa enggak. Kemudian biasanya pada pemeriksaan USG yang jinak itu terjadi yang kita sebut dengan hiperechoik pada kapsulnya. Jadi hiperechoik itu jadi lebih apa ya? Lebih putih. Ya, ada benjolan, ya hipoechoik dilapisi dengan hiperechoik. Dengan gambaran yang ketegasan pada batasnya. Itu kalau kurang dari 35 tahun. Kalau lebih dari 35 tahun disarankan mamografi kalau misalnya kita curiga. Itu imaging. Yang ketiga itu adalah histopatologi. Jadi tadi kita ulang lagi, physical examination, imaging, dan histopatologi. Ingat, histopatologi, bukan sitologi. Histopatologi itu adalah kita mengambil jaringannya beserta microenvironment di situ. Dengan cara apa? Dengan cara biopsi. Biopsi dengan caranya tadi itu yang sudah disampaikan, bisa dengan stereotaktik udah agak jarang ya kita temui. Bisa dengan cara VABB ataupun bisa dengan cara core biopsi. Kalau misalnya nggak bisa, nggak ada iniannya, bisa dengan traditional biopsi, excisional biopsi atau incisional biopsi. Jadi begitu ya. Kalau misalnya memang penegakan diagnosa tumor, apalagi tumor solid, itu harus mencakup tiga tools diagnosis, yaitu pemeriksaan fisik, imaging, dan histopatologi. Demikian Mbak Mega, mudah-mudahan menjawab.
Baik dok, terima kasih atas jawabannya yang sangat komprehensif. Kemudian ada pertanyaan lagi, bagaimana pendekatan bedah pada pasien kanker payudara yang telah menjalani kemoterapi neoadjuvan?
Bagaimana cara pendekatannya? Didekati aja dengan baik-baik. Jangan dijauhi. Itu yang nanya siapa ya? Ya. Pendekatan pasien pasca kemoterapi. Ya, betul ya? Pendekatan pasien pasca kemoterapi. Ini pasien sudah dilakukan sudah dilakukan operasi atau belum? Kemoterapi settingannya apa? Kemoterapi settingannya apakah dia settingannya itu neoadjuvan, adjuvan, paliatif, terapeutik. Kalau misalnya dia neoadjuvan, ya, kita melihat biasanya setelah dilakukan neoadjuvan, kita melakukan suatu reassess. Ya, kita lakukan restaging. Kemudian kita evaluasi dengan satu yang kita sebut dengan seberapa respons tumor ini dengan neoadjuvant kemoterapi itu, ya kita akan menilai nih, respon nggak nih? Kalau sebelum kemoterapi besarnya 10 cm, setelah selesai kemoterapi, ini bedah nih mikirnya, setelah selesai kemoterapi dia masih 10 cm, terus lu pakai apaan kemoterapinya kemarin? Berarti kan gagal nih. Harusnya kan kemoterapi itu kemoterapi neoadjuvant fungsinya adalah itu untuk downsizing atau downgrading, ya, downsizing atau downstaging. Kalau enggak, setelah kemoterapi ternyata stable disease, ya ini bisa operable apa enggak? Kalau misalnya operable, ya kita lihat dulu, ini baru layer pertama, kemudian dilihat lagi molekular profilingnya seperti apa, benar nggak yang sudah diberikan NAC-nya kemarin, itulah maksudnya. Kalau kemoterapi kan gini, kalau misalnya layer pertama dia kagak goyang, ya naikin dong layer kedua, ya layer 2 kagak goyang, ya naikin layer ketiga, kan gitu kan, sampai kita bisa melihat respon daripada tumor tersebut terhadap neoadjuvant kemoterapi, ya. Nah terus kalau misalnya 1 nggak bisa, 2 nggak bisa, 3 nggak bisa, operable apa enggak? Operable. Kalau operable bisa, ya kita kerjakan operasi. Kalau operable loh, kita bisa memaintain margin, ya, safety margin, kita angkat, ya. Tentunya dengan followed by radiotherapy. Terus bagaimana kalau misalnya NAC post neoadjuvant kemoterapi, dia ada beberapa kemungkinan lagi. Dia itu mungkin partial respon atau full respon. Kalau gitu mah gampang atau kalau gitu ya kita lihat setelah di kemoterapi yang tadinya 10 hilang nih, bisa terjadi kayak gitu. Kanker payudara di kemoterapi hilang, ya kan? Di kemoterapi hilang, kemudian kita mamografi deh. Oh, nah, ada batas jelas, masih ada gambaran distorsi dan klasifikasi di dalam. Jadi itulah makanya pada saat incisive biopsi itu harusnya kita tanam titanium tuh, klip. Jadi kita tahu sebenarnya di mana. Kadang-kadang tuh ya, saking jagonya Dokter Agus dan Dokter Luna, ya, Dokter Agus dan Dokter Luna mencari terus, itu bisa-bisa hilang beneran. Tapi yang kita harus tahu, kita tetap harus masuk surgery tetap harus masuk, karena ketika dia tidak ini ya, sel cancer ini kalau setelah dia tidak di covered by kemoterapi atau target, dia akan tumbuh lagi. Jadi seperti itu. Kalau misalnya ternyata hilang atau menjadi lebih kecil, kita bisa melakukan reduksi dalam prosedur surgery-nya. Bisa kita lakukan kalau tidak ada multisentris dan multifokal dari mamografi, ya kita bisa lakukan breast conserving surgery. Jadi tergantung dari apa yang ada di hadapan kita. Seperti itu. Itu kalau misalnya kemoterapi settingan neoadjuvan. Kalau kemoterapi settingannya adjuvan, ya udah tinggal kita lihat molecular profilingnya apa. Kalau molecular profilingnya itu misalnya ER/PR, high risk, mau kita apain nih? Ablasi. Kita ablasi ovariumnya pakai apa? Bisa pakai chemical, bisa pakai surgery. Bagaimana caranya? Kita lakukan breast bilateral salpingo-oophorectomy. Jadi seperti itu. Banyak yang bisa kita lakukan. Demikian, mudah-mudahan menjawab, Mbak Mega. Actually, I want to answer this in English, but you don't let me. So, I give this answer in Indonesian languages. Oke, mudah-mudahan menjawab.
Ya. Terima kasih Dokter Prabudi atas jawaban pertanyaannya. Kayaknya kalau pakai bahasa Indonesia tuh lebih nyes gitu loh. Personalitinya keluar semua ini gitu.
Oke, oke.
Nah,
Ya asik ya lebih
kemudian
Indonesia ya.
iya lebih
Terlalu
jos
formal,
personalitinya.
terlalu formal. Yang keluar auto. Oke.
Iya, biar ada variasi.
Sip, sip, sip.
Baik, kepada para peserta, jika ada yang ingin ditanyakan lagi, silakan gunakan fitur raise hand atau chat box. Oke, jika tidak ada lagi yang ditanyakan, terima kasih banyak Dokter Prabudi atas pemaparannya dan jawaban-jawaban dari pertanyaannya dan pantunnya. Terima kasih banyak.
Terima kasih.
Baik, jadi kita masuk closing ya. Thank you to our esteemed speakers for your invaluable insights, to the organizers for your dedication, and to all participants for your enthusiastic engagement. This event marks a proud milestone as actually our first international webinar, and your presence has set the stage for even greater success in the future. To our speakers, we are truly honored by your contributions and hope that you will join us again as we expand and welcome an even larger global audience in our upcoming events. Please remember to complete the attendance form and finish the LMS materials within 2 days after clicking the Start Learning. We hope this webinar has inspired and empowered you. See you at our next event, and thank you for making this journey unforgettable. Stay healthy and take care.